Good morning, everyone, and welcome to the House Committee on Health, Human Services, and Elderly Affairs. We have several bills that we're going to be hearing today, but before we do that, I'd like you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. First bill to be heard today is HB 1760 FNA, and I'll recognize prime sponsor, who is already seated at the witness box, Representative Tulerski. Welcome, Representative Tulerski.
Thank you. Good morning, Mr. Chairman and members of the committee. For the record, I'm Laura Tulerski representing Hillsborough 11, Nashua's Ward 8, and I'm here to introduce House Bill 1760 FNA, what we are calling the Protecting Access to Affordable Health Care for Working Families Act. As you all know, the state budget signed in June included direction to the department to seek a waiver to establish pharmacy copays and Medicaid premiums, and this bill repeals that directive. As you can see, the bill's quite short. Section 2 directs an appropriation to make up for the revenue that had been expected from these programs, and Section 3 is the language to strike copays and premiums from granted Advantage in the Children's Health Insurance Program, known as CHIP. I originally filed this bill because I fundamentally disagree with the concept of Medicaid premiums. Medicaid recipients are, by definition, our lowest income and most medically vulnerable neighbors. These people do not have enough to make ends meet, never mind any extra at the end of the month. Even modest pharmacy copays of a few dollars can become a real barrier, leading people to delay or skip medications. And for working families struggling to afford rent, food, and basic necessities, adding a monthly premium to access health care often means they will simply choose to go without coverage. We know that preventive care is the smart choice because prevention has a much lower price tag than advanced sickness and the hospitalization and treatments that accompany it. We also know what happens when preventative care becomes unaffordable. People go without coverage altogether, leading to delays in treatment until they are much sicker. They end up in emergency departments and hospitals with advanced sickness, costing more, and because they don't have insurance coverage, driving up uncompensated care. Ultimately, in the end, all of us are paying for it one way or another. While I do not believe the state budget should be balanced on the backs of our lowest income residents, there's now more to this story that we did not know when the budget was signed into law. Our budget took effect on July 1st. Just days later, on July 4th, the president signed H.R. 1, the OBBBA, which significantly changed the federal healthcare landscape. That federal law directly conflicts with our new state policy by explicitly prohibiting monthly Medicaid premiums and instead requiring cost sharing through copays. This creates a very real and practical problem for New Hampshire. What we are now looking at is implementing Medicaid premiums here in the state for a very short window of time, roughly 18 months, only to have to dismantle that system and replace it with a different federally required cost-sharing mechanism. This cannot be an efficient use of our state resources if we move forward with premiums for the short term. We are looking at administrative build-out, development of new software applications, and staffing for ongoing support and maintenance services, enrollee communication and education, eligibility determinations, and enforcement of non-payment, all for a policy we already know won't last. Instead of pursuing a temporary and conflicting policy, this bill allows the department to focus its limited resources on planning for and implementing the federal requirements thoughtfully and correctly without wasting time and money. I sit on the House Finance Committee, and sometimes when writing a budget, decisions are made and then more information comes to light and it's discovered the original plan no longer works the way you thought it was going to, and this is one of those cases. With that, this bill protects access to care for our most vulnerable residents, focusing on prevention, which is the right thing to do. And for those reasons, I urge you to consider an ought to pass recommendation. Thank you.
Thank you. Any questions? Representative Lucas and then Representative Palazzo.
Thank you, Mr. Chair. Thanks for taking that question. Is there an estimate of what this temporary software change and system support over 18 months would actually amount to?
Thank you for the question. I was refreshing the bill docket up until about 9 o'clock last night looking for a fiscal note. And the answer is no, we don't know. Now, with that related, I would say that we don't necessarily know exactly what the cost of those premiums was going to be, because there never was any concrete knowledge of who was going to pay, who was not going to pay, who was going to drop off, who was maybe going to miss 1 month, and what would happen if someone missed 1 month. There was just so many questions that remained unanswered.
Representative Palazzo.
Thank you. Yeah, you answered most of my questions with your previous answer. But what timeline we are looking at here? Like when we would know more? Like if this bill is not passed, when we will start feeling those effect of those premiums?
Thank you. I believe that the HR1 mandate goes into effect October 1st. I think I just saw this will have the specific details on that date, but I think it's October 1st of 26. We'll get to that.
Other questions? Representative McLean.
Thank you, Mr. Chairman. Thank you for taking my question. So there's two components. There's the copay component and the premium component. Are these both currently in the same state of existence right now? We're just building the application on the plan, but nothing has gone forward at this time?
I believe we are still in the launch of that, and it's supposed to start in a number of months.
Thank you.
Other questions? I'm seeing no other questions. Thank you.
I appreciate your time. Thank you so much for your consideration.
Sure. Also signed up to speak is Representative Stringham. You've asked for 5 minutes, Representative. If you could keep it closer to 3, I'd appreciate it.
I'm sure that'll be plenty. Thank you very much. Pleasure to be here with you. I'm Representative Jerry Stringham from representing the towns of Lincoln and Woodstock and Easton in the North Country. The Medicaid program is obviously very important to those of us in the North Country and very concerned about the implementation of this portion of HB2. Obviously, the people affected by this, which are those who are working but currently making enough money to qualify for Medicaid, will be asked to pay a premium to continue in the program. Already we have challenges with this group. I had one resident who got their $25 a week pay increase at Dunkin', and that moved them from being eligible to non-eligible. So essentially they lost their health insurance while they had a little bit more money to deal with. That doesn't work for anybody. I'm specifically wanting to focus on what the net impact of this is to the New Hampshire economy and to our overall healthcare program. Basically what this talks about is people who are eligible paying a portion of the premium, up to 5% roughly is what it comes out to. Some may pay the premium and stay in the program, but many will not. In the cases when they don't, not only do we not get the premium, but we lose the federal funds that come with it. So in some cases, that's 90% of the total premium in the CHIPS program and Granite Health Advantage. So that's money that's coming out to pay for health care in the U.S., in the state of New Hampshire. So what happens? Some of those people don't have health insurance. They still go to our federally qualified health centers to seek care when they have to, and you never know when you're gonna develop an injury or something else that requires care. Those centers and some of our hospitals are required to provide care regardless of the abilities people to pay. There's just going to be less total money to pay for that. So what's going to happen? Some of those centers are going to not be able to be financially viable. In my area, up in Franconia, due to anticipated Medicaid cuts, they already have closed a clinic that has been open for 25 years, the Amanuensis Clinic in Franconia, and there's others making similar choices. So I think the idea that collecting premiums, which on another bill may represent $11 million for those in the CHIPS program and $4 million in Granite Health Advantage, could take away hundreds of millions in healthcare dollars in lost premiums. And so what's going to happen? Those that stay open are going to have increased bad debt, and they're going to try to, when they can, offload it onto those people who do pay premiums. Health insurance goes up for everybody.
Start, wrap up, please.
And so it's a folly exercise. It's something that went through, and I encourage the passage of this bill. Thank you very much.
Thank you. Any questions? Representative Lucas.
Thank you, Mr. Chairman. Thanks for taking my question. So that 90% federal contribution just goes away when someone drops their coverage?
Right. If they're not in the Medicaid program, and the 10% state contribution to that is not made, then the 90% from the federal does not come in.
Thank you.
Other questions? Representative McLean.
So yeah, thank you, Mr. Chairman. Thank you for taking my question. So, and just to clarify on the mechanics of the one big beautiful bill, the prime sponsor mentioned that the premium portion was going to be in conflict with the federal law. Is that also the case? Are you aware with the prescription copay portion?
I am not aware of that.
Okay, thanks.
Other questions? Saying no other questions. Thank you. Also signed up to speak is the Honorable Melbourne Moran, Jr. Sir, you asked for 5 minutes. Again, please keep it to 3.
You turn on your microphone?
Yep, there you go.
Good. All right. Hi, Melbourne Moran Jr. I live in Nashua. I also work in Nashua, former member of the State House. Hi, former colleagues that I can remember.
Welcome back.
It's good to be back, especially on this. So I also sit on the board of the NSAW New Hampshire for social workers and the National Super Kitchen and Shelter. But I'm speaking as the owner of One Less Therapeutic Services. I own and operate mental health agencies in headquartered in Nashua, have office in Manchester. We provide telehealth throughout the state of New Hampshire. And I also operate in Massachusetts, Washington, and other locations yet soon to come. We have about 50 or so employees here in the state of New Hampshire, and serve about 2,000 patients here in New Hampshire as well. Providing outpatient mental health, no psychiatry, meds, stuff like that. I'm not a big fan of those things. But the premiums and the co-pays, I just want to give a provider side. The people who will end up actually paying and losing will be the small business providers. We don't have access to grants. We don't have subsidized anything. I take Medicaid to help increase access to mental health services. I already have to deal with the whims of the government, left to right, up and down, about how to, on the budget here, to create my own budget. I can tell you that if someone's paying a premium for Medicaid, they're already not able to do it with their employer-based plans or their ACA plans, and the cost shifts to the provider. One, we either get a letter in the mail a couple of months later that says they didn't make their monthly premium, and I have to pay it back for some reason, because somehow that's my fault. But the insurance companies get to keep all their cash they've been making, or the government, or whoever it might be. Copays, I know that it applies to pharmacy, but in other states I've operated in, I see copays on mental health, whether it's $1, $5, etc. There's a slippery slope. Again, who's paying for it? Most likely not the person who can't afford $1, so I have to take the cost of that. On top of the other fees and problems that come with Medicaid already, and ACA plans and employer-based plans, you guys could do some practical things like telling AmeriHealth to stop charging me a fee for a direct deposit, where New Hampshire Healthy Families and Wealth Centers don't do that. But they all add up. It's a microeconomy. All these little minor fees that I have to be skimmed off the top before I can even get it to pay my people who are in high demand in the state of New Hampshire. And because of the flip-flopping of the legislator, I've had to expand more into more stable markets like Massachusetts, Washington, looking at even Florida. And yes, that money comes back here to stabilize New Hampshire jobs. Because I have to do it that way, because I'm not exactly sure where you guys are going to go with Medicaid, whether it's going to be a cut in the rates or allowing premiums or copays, etc. And I can't rely on you guys to make decisions all the way up to the last day to vote on something where I have to plan ahead to keep care of not just my own family and my children, and I have another baby on the way, doing my Catholic duty, 4 girls soon. So, but I'm responsible for just over 50 people nationwide and their families to get paid well and to support them. And that's a big responsibility. And dealing with the government is the worst. What was that?
If you could start wrapping
Yes,
up,
I
please.
can. Thank you. But just keep in mind that it's not just this. There's all linked together. There's fees associated with everything. And it always comes down to the provider who has to pay it back, who has to lose off revenue, while the state and the insurance companies shift all the problems to us to deal with because we're client facing. I have so many stories, but we're going to wrap it up. So, but thank you for your time.
Thank you. Any questions? Representative Blazow.
Thank you, Mr. Chair, and thank you for your testimony and taking my question. So, out of 2,000 patients in New Hampshire, what share on relied on this program and could be affected by those?
We're looking at about a 40% share of clients are Medicaid. Majority of them are also children. And we are one of the few private practices that also see children 5 and up, which is rare in the state to see that age group plus take Medicaid.
Other questions? See no other questions. Thank you.
Great, thank you.
Also signed up to speak is Director Henry Lippman from the Department of Health and Human Services, Medicaid.
Good morning. Henry Lippman, State Medicaid Director. I'd like to cover 2 aspects of this, kind of what's in OB3, HR1. So the cost sharing requirements come into effect October 1st of 28. States would be required to impose cost sharing on only expansion adults who are within 100 and 138% of poverty. So anyone less than 100% of poverty, there is no cost sharing. Cost sharing is also limited, has to be more than 0, but can't be more than $35. The total aggregate of all cost sharing cannot exceed 5% of the family's income. There are certain services that are excluded from cost sharing. Those include primary care, prenatal care, pediatric care, emergency care, except for non-emergency care provided in emergency rooms, or services provided by an FQHC, CCBHC, Community Behavioral Health Clinic, or mental health center, or a rural health clinic. So it is somewhat circumscribed in terms of where it can be applied. That was what's in the bill. Taking a step back, looking at state policy that was approved in the budget. I think the numbers talked about earlier were, I think it was 11 million in the children's space, which was would be applied to only those children that are 255% of poverty or above. more than half the states don't even go up to 255%. So it would be only, and that represents about close to 90,000 children. It's probably about between 7 and 8,000 children that would be applied to. In the adult population, the premiums would be only applied again in that 100 to 138%. The reason, sort of the policy choices when, working within the budget guidelines that we had to work with, we really have how you can control a Medicaid budget is, premiums and cost sharing is one way. Reducing eligibility, which the governor did not want to reduce eligibility, so there was no changes in eligibility, and the other is to cut services and what you cover. So really there's sort of three main policy levers. Obviously, improving efficiency and gaining quality are other ways that you can do that as well. But in terms of trying to commit to, a budgetary improvement, looking at premiums and was, I think, the most prudent area because it also did not shift the burden to providers in terms of the administrative effort of collecting the cost sharing, or and that premium spreads it out among all recipients, if you will, all people who use the service, not just those who, all people, whether you use the service or not, like general insurance, in terms of managing the risk you're sharing across the broad population, as opposed to only the sick people who end up needing the service.
Yeah, we could start wrapping up this.
I'll stop there and take any questions if that's okay with you.
Sure. Thank you. Any questions? Representative Mazer.
Yes, thank you for taking my question. So, what's your stance on this bill then?
So I think that in terms of, I was coming here to provide information. I mean, it's in our budget to, so I do have to come in supporting that we continue with what was in the plan there, because if we don't have this source, I have to find it from the other areas that I talked about, which I think, directly addressing eligibility, which the governor does not want to do, or cutting services, which, is a very difficult thing to do. I think this is really one of our only policy levers where we have a budget requirement to meet, and it's going to be challenging. We have been in conversations to make sure that with CMS that have been affected by the implementation, their bandwidth has been affected by the implementation of the OB3 bill, but we want to make sure that we're aware of all the intricacies with children in particular, that there's 12-month continuous coverage. How, if someone isn't paying the premium, how we deal with that. I know the governor wanted us to be sensitive to that situation if people were in treatment and such. So there's a lot of time that's been put into working with CMS and working these things out. And in terms of developing a budget of what it's going to take to implement it, I think we're talking a number that's less than $1 million to implement this type of activity, whether it include cost sharing or not. But it's really hard to get a vendor to give you a price if you can't tell us all the specifics yet. So we're kind of still in the information gathering stage. We're a bit behind where we wanted to be. We wanted to be implementing children's premiums sometime in this first quarter of this calendar year, and our time frame for expansion was starting in fiscal year 27. Again, part of our challenges, we probably will have some challenge meeting the budget numbers based on the delays that we're experiencing and working out the finer details with CMS. So we really need this revenue source to be able to address the budget, or we have to take it from somewhere else, which I think is in a less favorable way.
Follow up.
Yes, thank you for that. I'm still not clear though.
I would be opposed
Yes.
to the bill because it would force us to make, I think, less favorable policy choices. I understand why this is not viewed favorably, but I think of the policy choices we had, this is the.
Thank you. Appreciate it.
Director, I may have asked you this question in the past, but Medicaid is, I know when I was in the department, it was like 70% of the department's budget. Is that still the case, or is it a different amount now? Or?
I think I'm better on. It's almost. I mean, the whole Medicaid program's like around a third of the state budget, right? So it's in that realm in terms of total spending. I think in terms of the department, it's probably more than 30%. It's probably in the 40% range.
It's only 40% of the department's budget?
I think it's in that.
'Cause I
But
thought
I'll
it
have
was
to confirm
70%
that
at one
number.
I thought it was 70% at one time, so it's actually not as bad. Sounds like.
I'll confirm that number. I apologize.
Yeah, just curious.
Yeah.
Because I know that the department's budget is over half the state budget.
Yes.
so.
And so I'm trying to. I think when I'm having a little difficulty recalling at the moment is when we're talking either general funds or total funds. So I need
Sure.
to, because we do in the Medicaid program, a lot of our funding comes federally in terms of, like was talked about earlier, 90% for the expansion population comes from the federal government, 65% for kids that qualify for the Children's Health Insurance Program, and 50% on the rest of it. In other areas of the department, like nursing home care and home health and CFI, it's all 50%. So I can get back and share
That's
that with
fine.
you.
Sure. Thank you. Representative Lucas. And then
Thank you, Mr.
Representative
Chair.
Lamontagne.
And thanks for taking my question. Could you just clarify for me, would this bill return some of the federal monies to your budget or take them away?
So I think in terms of if we're talking premiums here for a moment, that it would reduce the amount that we would have to come up with general funds or other funds, but would also, because we're not spending as much, it would also reduce some of the federal share too. But the net effect is what I was referring to, the 11 or 12 million, depending on which program we're talking about.
Follow up.
Follow up, thank you. 11 or 12 million, that would be an additional cost
No, that
or would be of an improvement in your budget with this bill? I'm just trying to understand the impact.
so the budget currently is carrying. I'm trying to help the clerk here a little bit too.
Sure.
11 million for the children's program and 12 million in new revenue, if you will, which would allow us to meet our budget target. So the premiums are an important part of being able to meet our budget obligations, if you will. Okay. How premiums affect our federal claiming is a separate question, right? So if we're collecting premiums, that brings down what our capitation number has to be, or our insurance premium that we're paying, which reduces the federal amount a little bit. But the net effect of what we're expecting is that if this bill was passed, that we would not be able to gain any of that revenue that we were anticipating.
Thank
So
you.
If in large sum total, think about it this way, it'll create a $23 million hole in terms of what Medicaid has to contend with.
Representative Lamontagne.
Thank you, Mr. Chair. Well, part of my question was answered, but what do you think of the impact might be if, as a previous speaker suggested, there might be a lot of people that drop out because of these premiums? Have you anticipated that there would be a certain number that drop out?
I would anticipate that there would be some that might choose to drop out because they have other financial commitments that they're trying to address. I mean, again, in terms of the population that we're talking about here, out of today about 170,000 people in the program, we're talking about somewhere in the order of 20,000 at most that would, between the two programs. I don't have a sense of what percentage would drop. We do, our number of 11 and 12 million is based on a collection rate that's less than 100%.
Other questions? Representative McLean.
Thank you, Mr. Chair. Thanks. for taking my question. So, and I'm just trying to understand too, because when the prime sponsor introduced the bill, you know, she was stating that there is going to be a conflict with the federal law, and if I understood it correctly, I thought premiums would not be allowed, and yet you just testified that as of October 1st, cost sharing is going to be mandated. So I'm just trying to understand the nature of the conflict, because one of the arguments of the sponsors is you're creating this entire infrastructure which has to go away. But I'm thinking if cost sharing comes in October of 2028, you could just build it in line with that. So it's a bit of a soup in my mind. Maybe you could clarify.
Yeah, thank you. With the 3 minutes, I didn't think I could get into all that, so thank you for the question. So let's talk children's premiums. We can do that through a state plan amendment, and so we can do premiums and no cost sharing in that group. The cost sharing only applies in the OB3 bill in 2028, as you said. So I think in terms of doing premiums in expansion, we're trying to ascertain with CMS. We believe that there's a good chance that we're able to do it through a waiver. There are other states that have premiums in that expansion group today, and they've done it through a waiver. So that would be the approach that we think we get. I think the complicating factor that has come up is once the passage of OB3 came through as to whether you can do premiums or not. We believe that there's a path to getting to doing premiums, but I can't say today with 100% guarantee. But I believe, based on our conversations, I think we could get there. Then the other question is, can we do the waiver to waive the cost sharing and just have premiums? And so there's a couple unanswered questions there. I do feel that the incremental difference of having premiums and cost sharing, that shouldn't be what drives what we do, because I think that the incremental cost of doing that, I do think that cost sharing is less desirable because it pushes the cost onto the providers and complicates the whole administration of the program for them and their offices. So I wish I had a definitive answer for you all today. Being honest with where we're at is that we know that there's a path for doing it through state plan for children, and we know other states have been able to get a waiver to do premiums in the expansion group. The issue is, I think federally is adjudicating how the OB3 HR1 interfaces with a request for premiums.
Follow up.
And so, and the $12 million is a pretty big nugget. The bill says that it's going to make an appropriation from the general fund. Are you aware? Is there money there to cover that as put forth in this bill, or are you going to come up short, do you think?
Well, I think to the extent that we're delayed, we're going to have to find other mechanisms to make up that difference. But I think in the first year we only planned in the children's premiums for $3.3 million, and the ultimate on a 12-month type of basis, that's when we planned for 11. There are the factors that the time the legislation was passed versus where we are today that we're still working to clarify with CMS in terms of what limits we have in collecting premiums in children. On the expansion side, the complicating factor is how does that statute intersect with previous waivers that have been granted for premiums.
Another question, Representative Palazzo.
Thank you, Mr. Chair, and thank you. I have two questions, if I may. So first is, like you mentioned, other states. So is it comparable? Can we compare the states who already implemented premiums, if it's comparable, what were effects in those states, and also if you could clarify timeline. Did I understand correctly that we are talking about April 2027 and then 18 months to October 2028? Is that timeline that this bill affects?
So I think that the bill, as I read it, would affect our ability to implement the children's health insurance premiums in this current fiscal year, or minimally, I guess depending on the day that it's signed, it would affect us in state fiscal year 27 forward. In terms of the expansion population, if it was signed into law, it would take out our ability to implement that in state fiscal year 27. In terms of states that have premiums, it's not a red or blue thing. There you'll find states in both categories that have premiums. The amount and cost sharing things can vary, but it isn't a red or blue thing. That's, I guess, the way I would characterize it.
Representative Palmer.
Thank you, Mr. Chair. Thank you for taking my question. I think you earlier were sort of saying you don't really have a good idea of how many people will not be able to afford to stay in the program and will drop it. So, but I guess if there's any way to know more, so I'm on the board of Valley Regional Hospital, which is a critical access hospital in Claremont. And when we did our budget this year, there's the budget, and then there were 3 levels of what happens with different things in Medicaid, both state and federal. And the rate, I mean, basically all of them put the hospital in the red. Some of them put the hospital in the red with maybe only a year to go before poof. So I guess, is there any way that, or any estimates that you're thinking about that you might be able to?
So within, I think the bigger issues for hospitals, and just by way of background, I was a CFO of both a critical access hospital and a larger hospital before I came to this position for a couple decades. So I know the challenges that you speak of, and I know Valley Regional Hospital well. So I think the bigger challenges that are in HR 1 OB3 are related to the federal requirement for work requirements, and also twice annual redeterminations on people who are on Medicaid expansion. For that, I think the numbers that are out there, the potential coverage loss, and when I give you this number, it's not that it's a certainty. It's without making other changes and trying to, do more to protect people who are eligible, remain eligible. But it's in the neighborhood of like 9,000. In the children's area, again, I would expect that we're talking maybe hundreds, not thousands, because we're dealing with a much smaller base.
Thank you.
Other questions? Seeing no other questions, thank you.
Thank you. I will get back to you on the budget percentages. I apologize.
No, that's fine. I appreciate it. Also signed up to speak is Greg White from Lamprey Healthcare. And again, sir, you've asked for 5 minutes. If you could keep it to 3, please.
Yes, sir.
Thank you.
Good morning, Mr. Chairman and members of the committee. My name is Gregory White. I am the co-CEO of Lamprey Healthcare. We are a federally qualified health center, not-for-profit, and we are the medical home for over 17,000 Granite Staters. I'd like to speak a little bit about the importance of New Hampshire Medicaid to our enrollees and to federally qualified health centers and other providers. We provide comprehensive primary care, substance use disorder treatment, mental health, and other services through our locations in Nashua, Newmarket, and Raymond, as well as our co-located programs at the Nashua Soup Kitchen, Good International Mental Health, and the Center for Life Management in Derry. We also provide services through a mobile health unit in the region. Our patients come from over 40 communities within Rockingham, Hillsborough, and Stratford County. Over 70% of our patients with known income are at or below 200% of the federal poverty level. 41% of our patients are either uninsured or on Medicaid. The Granted Advantage Healthcare Program provides just over 52,000 adults with vital healthcare coverage, including preventive and primary care, mental health, substance use treatment, diagnosis and treatment for diabetes, hypertension, and cancer. To qualify for insurance under Granted Advantage, a person's yearly income must be at least at or below $22,000. Approximately 1,100 of our patients are insured by the Medicaid Advantage program, an equal number under the Child Health Insurance Program. And thankfully, the concentration of uninsured patients in most of our service area has dropped since the implementation of this program, greatly improving our ability to serve our patients and to connect them with services and medications outside of our walls, removing barriers to care. That allows us to keep them healthy. Policy changes made to the New Hampshire Medicaid program in Washington and Concord affect our patients and Granite Staters' ability to access healthcare services. The New Hampshire legislature added co-payments and premiums to the Granted Advantage enrollees and the CHIP program last session, which will create financial barriers for our patients and their families. Requiring premiums also conflicts with the OBBA, which prohibits the collection of premiums and excludes certain services, such as those at federally qualified health centers, from cost sharing. It's now February 2026 and we don't have critical information. Will New Hampshire Medicaid enrollees be forced to pay premiums that they cannot afford? Because FQH services were exempt from cost sharing in the OBBA, will FQHC's patients be exempt from the cost sharing requirements in the state budget? FQHCs were established by federal law and are regulated by the Federal Health Resources and Services Administration. How will we manage conflicts between federal and state laws? Also, what happens to our Granted Advantage and CHIP enrollees when their health insurance becomes too costly? Just one final point I'd like to make is that as a federally qualified health center, by rule and by law, we see patients without regard to their ability to pay. So where we are no longer reimbursed by Medicare, it becomes uncompensated care for the services we provide.
Thank you.
Thank you.
Questions? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So we previously heard that some hospitals might be put in the red by current changes. So I wonder, like, what hospitals can do short of like closing doors, and like what percentage of your expenditures are not directly related to providing healthcare? You mentioned soup kitchen. In my view, it's a noble effort, but it's not directly providing healthcare to your patients. So are there some ways you can do some cost saving?
Certainly. Thank you for the question. I would say that as a service organization, the majority of our expenditures are on staffing, which is our most highly valued asset. Certainly our programming at locations like the soup kitchen or our integrated care at the community mental health centers would be at risk, given that they are a low volume, high touch type of service. I would say the outcomes at the other end would be impacted, where we are actually preventing we're preventing higher utilization in, say, emergency departments where the cost is multiples of the primary care setting. A little harder to quantify things that don't happen. The other alternative we have, if we were to go into the red, is we actually have to start thinking about rationing the quantity of service that we can provide. We would have to get smaller.
Representative Lucas.
Thank you, Mr. Chair. Thanks for taking my question. In particular, could you explain the effect of this bill as it is currently worded on your organization's bottom line?
On the bottom line, I guess my concern would be, do I have a fair number of our patients that are presently covered by Medicaid, CHIP, or the Advantage program that would become uninsured? So I've got 1,100 that I mentioned earlier. I would say a fair amount of those would become uninsured and potentially subject to a sliding fee discount, which is uncompensated care for us. Certainly, it would take us from, I would say, less than a modest positive bottom line in our budget to a fairly significant negative rating.
Follow up. This bill would take you to a,
Excuse me, this bill would prevent that. I'm sorry.
thank you.
Other questions? Representative McGrath.
Hi, you had said that your uninsured dropped since implementation. I'm assuming that's the grant advance since implementation.
So Medicaid expansion, which I think was the predecessor to this program, at least the descriptor for it occurred, I think, in the early teens. We saw our uninsured rate go from well over 25% down into the mid-teens as a percentage.
Follow up?
Follow up.
Thank you, Mr. Speaker. So that was, you said, the 1980s?
Excuse me, in the like 2014, 2015.
Oh. So,
Follow up.
sorry.
That's okay.
So so it was 25% before, and what does it look like now?
So uninsured as a whole is about 17%.
Thank you.
Other questions? No other questions. Thank you.
Thank you, sir.
Also signed up to speak is Sam Burgess from New Futures.
Thank you. Good morning, Chairman McDonald and members of the committee. My name is Sam Burgess. I am the Healthcare Policy Director at New Futures. We are a nonpartisan, nonprofit organization that seeks to find policy solutions for New Hampshire's problems. New Futures strongly supports this legislation as the new premiums and cost-sharing measures for Granite Staters enrolled in CHIP and Granite Advantage are going to overburden low-income families and cause measurable harm to their health, financial stability, and access to care. And I think it's important to underscore, as we've heard from our previous speakers, that these harms are not hypothetical. States that have implemented similar premiums have seen immediate and significant coverage losses. If we look back in 2003 to Oregon, the state charged sliding scale premiums to enrollees below the federal poverty line and implemented lockouts for non-payment. In the first year alone, enrollment dropped by nearly half for the affected population. Those who disenrolled in Oregon were 4 to 5 times more likely to report to the emergency room as their usual source of care than for people who remained enrolled. That's additional uncompensated care for New Hampshire providers already facing financial strain. I believe Representative McLean and Representative Lucas asked the question earlier, if we lose these enrollees, do we lose the federal dollars? And I think it's important to underscore, as the previous speaker did, that not only are we losing the federal dollars, but these healthcare needs do not go away. These are still people who have these needs and are going to go to either FQHCs or hospitals with emergency departments who have an obligation to see them. And those uncompensated care, that uncompensated care is ultimately going to be borne by the state, counties, and taxpayers should the state choose to subsidize those providers. It's also important to note that charging premiums and other cost-sharing measures have historically failed to save the state money. A study conducted by the American Economic Review confirmed that increasing premiums leads to lower cost enrollees disproportionately dropping out of Medicaid programs, raising the average cost of the remaining insured population, and contributing to increased average medical claims. In that respect, cost sharing will bring unintended additional costs to the state. Beyond the fiscal impact of these new costs, it's also important to highlight the human toll. These cost-sharing measures will force individuals and families enrolled in Granite Advantage and CHIP to make impossible choices between paying for housing, food, or healthcare. Years of research have shown that when individuals face copays, they use fewer services. That leads to foreseeable consequences: skip medications, foregone hospital visits, and avoidable hospitalizations. For those who manage to stay enrolled, their coverage becomes functionally weaker as new cost barriers prevent them from using it. Medicaid and CHIP are lifelines for our friends and neighbors in need. If the current premiums and copays stand, they are going to weaken our critical Medicaid programs and force people to lose their health insurance when they need it most. I'll wrap up by saying New Futures urges the committee to support our fellow Granite Staters and vote ought to pass on HB 1760. Thank you.
Thank you. Questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, you know, one of the problems that we heard from the testimony of Director Littman is in many ways the train has already left the station. But then, you know, you're citing a case or cases where this kind of cost sharing has been implemented in other states. You're seeing a 50% drop. And was that a 50% drop in the use of services or in the enrolled?
So yeah, thank you for the question, Representative. That was a drop. Half of the affected population who faced new premiums in Oregon were disenrolled from the program.
Yeah, that was it. So that's a spooky number. Like, oh, sorry.
Follow up.
So that's a spooky number. I think I heard the director say, you know, for us, the premiums would kick in at 255% of the poverty limit. Do you know where Oregon had that set up?
I do not off the top of my head, but I can certainly follow up with that question for you.
I mean, if you have any other information on other states, I'd like to understand the scale of this thing.
Certainly, and I'd be happy to follow up with the committee with some additional numbers on historical examples of how these premiums have affected disenrollment numbers in other states.
Thank you.
Other questions? Seeing no other questions, thank you.
Thank you.
No one else has signed up to testify on this bill. Does anyone else wish to testify on HB 1760 FNA? I see no one else wishing to testify, so I'm going to close this public hearing. Our next public hearing is scheduled for 10 a.m. on HB 1794 FN. We will be in recess until then. Representative Laura Tulerski, welcome back.
Thank you very much, Mr. Chairman. Thank you for having me again. For the record, I'm Representative Laura Tulerski from Hillsborough 11 in Nashua, and I'm here to introduce for your consideration House Bill 1794 FN. At its core, this bill is about being prepared. Medicaid is one of the largest health insurance programs in New Hampshire, with roughly 170,000 Granite Staters enrolled, representing about 13% of our population, including children, veterans, seniors, people with disabilities, and our lowest income residents who rely on this coverage to stay healthy and productive. At the previous hearing that we just had that discussion, we heard how a federal change just 3 days after our budget was signed into law has put us into a state of uncertainty and now find ourselves spending valuable resources on short-term changes. But the problem of premiums is just one example of the rapidly changing landscape when it comes to health care and Medicaid. What else is coming? How else can we be prepared? Who exactly will be impacted? How will we as a state respond to the rapidly shifting healthcare space? What can we do to ensure Granite Staters can access healthcare? And the answer to all of these questions is we don't entirely know. What we do know is we face significant uncertainty at the federal level regarding Medicaid policy, including changes to eligibility, funding, reimbursements, administrative requirements, and changes to the Medicaid enhancement tax, all of which will have real life consequences here. At the same time, our state's healthcare system is already operating under strain. Hospitals are reporting rising expenses and workforce shortages, with several operating at a loss, with rural facilities particularly vulnerable. Reimbursement rates for Medicaid providers in New Hampshire have been among the lowest in the region. We have had no increase in rates this biennium, and it continues to be hard for providers to attract and retain staff, pay competitive wages, or sustain essential services. Workforce challenges are real. Vacancy rates remain elevated in many areas. Sublivable wages continue for necessary workers like those in the Choices for Independence program, and other in-home services and healthcare employment just simply lags behind the growth that in demand. It feels like we are approaching, if not already at a crisis point, when it comes to healthcare being squeezed from all directions. And as legislators, we need to understand what's happening and what will be impacted to direct our policymaking. We're already seeing cracks in our system. Just last fall, Amanusa Community Health, a rural community health center in Franconia, closed, citing reduced Medicaid funding and reimbursement pressures. Now that community has longer travel times to get treatment, fewer local options, and heightened demand on the facilities that do remain. In this context, House Bill 1794 asks us to be proactive rather than reactive. We need to analyze emerging federal changes, model potential implications, and develop a roadmap identifying where statute updates or budget planning will be needed. Just this week, the New Hampshire Fiscal Policy Institute released a report that hints at the massive impact that is coming to the state. For example, if the new 3.5% cap that is coming for Medicaid enhancement tax revenue during state fiscal year 2020, sorry if I said that wrong, if the 3.5% cap that is coming was applied to Met revenue during fiscal year 2025, the state would have lost more than $271 million in revenue, including at least $149 million in foregone federal Medicaid matching funds. And our system just simply can't survive that. By acting now, informed by data and an understanding of our state's unique healthcare infrastructure, we can avoid destabilizing disruptions to coverage and care. This bill is about stability, stewardship, and responsible planning, and ensuring that Granite Staters have access to the care they need, and that our healthcare system remain viable even in the face of uncertainty. I appreciate the committee's time today, and thank you for having me.
Thank you. Representative Mazur.
Yes, thank you for taking my question. Have you spoken to DHHS, and have they verified that this is indeed something that they're not doing already?
Thank you for the question. So some of it they are doing. That is true. Some of this information is being compiled by outside organizations that are also concerned in digging into this. But what I'm hoping to do with this bill is to have a comprehensive package, let's say, of what's coming and what we can anticipate to better help us prepare. I think that the example of the Medicaid enhancement tax alone, we're talking about extremely complex, pieces of policy here that are going to have a massive impact coming down the road. So I just want to have a more directed approach to make sure that we have all the tools available to us.
Follow up.
Yes, thank you. I also don't see a fiscal note on this. Is that anticipated?
It came in very late, about a few days ago, late last
is it
week.
here?
Sorry, I don't mean to interrupt, but if I can respond to that, I believe that the fiscal note reflects the work needed to prepare, and because of their staffing situation, I believe it states they would probably put it out for a contract, to have a contractor do the work. But the real fiscal impact is us failing to plan for the future, and even small shifts in the funding. It's a small price to pay when we're talking about hundreds of millions of dollars that we risk to lose coming down the road.
Follow up.
Sorry.
Sure.
I'll just repeat again, and I'll ask them when they come up probably, has DHHS identified this as an issue? It seems strange to me that they aren't doing this already. Like that they're looking forward, they know the change is coming, and that they're not already seeking to identify the impact of the changes coming.
Right. And I appreciate the question. What we're looking for is answers to some specific questions here with the reporting dates that would then be delivered to all of us to use as a planning tool and a roadmap. So no, they are not preparing a comprehensive report and delivering it to us right now.
Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. This is admirable in terms of the data that we're trying to get. Sitting on the Health and Human Services Oversight Committee, we are already seeing some of this. Have you had a chance to review what they have done already? And they have a 10-year program. In addition, the Rural Health Transformation Project, and that has many of the dimensions that are outlined here. Is there a way to interface these such that we, as has already been queried, that we don't do more than we really need to, having the Health and Human Services Oversight Committee already doing part of this?
Thank you, Representative. That's an excellent question. And yes, I would love to be able to pull all the information together and have it available. This was rooted in, when I filed this bill, it was rooted in the uncertainty of HR 1 and looking at examples nationwide of how states were responding. I came across this as an executive order in the state of Michigan to look at the impact of what was coming and to be prepared. So if we can combine efforts and make it available, readily available to legislators, that would be meet a lot of what I wanted to do with this.
Thank you.
Other questions? Representative Polazov.
Thank you, Mr. Chair. Thank you for taking my question. Does this bill direct looking only at negative changes, like in line 13, you talk about downshifting? For previous bill, we heard that some changes might help New Hampshire to keep more money. So, will the department be able to look for positive changes?
Thanks for the question. I hope so. I think that would be part of the big picture, is if you're saying, tell me about the negative changes, there could be instead, we actually find positive changes here.
Other questions? Representative Drew.
Thank you, Mr. Chair. I'm relatively new at this, but it seems really unusual to be specifically asking a department for a report. We already have multiple advisory bodies and committees and commissions that are, at least in theory, studying these exact questions. So I'm curious as to what the reasoning is behind ordering the department to produce the report instead of adding a task to a particular committee, such as the Medicaid Advisory Committee, or the Medicaid Beneficiary Advisory Council, or the Health and Human Services Oversight Committee, or the Healthcare Reform Oversight Committee. So why would you not add to their mandate instead of specifically asking the department to produce the report?
Thanks for the question. In my experience on Finance Division 3, where we deal with the budget of the department, we have had bills similar to this before, where we ask them to dig in and produce a report on a certain policy area or subject matter. So I guess I'm acting based on what I know and what I've experienced.
Anyone else? Oh, Representative Weber, welcome back.
Thank you very much. Thank you very much, Mr. Chairman. Thank you for taking my question. Am I not correct in thinking that not only do we, the legislature, ask all kinds of departments for reports all the time, but as we have heard again and again, it is we, the legislature, who are responsible for setting the policy. And so it is we that need these reports. And the purpose of this report is to fill in the gaps, because all of the things cited by Representative Woods are available, but they're no way integrated into the picture that we need to see where the 10-year plans that we have are completely now irrelevant, and where they have been, as Representative Palazzo said, actually helping us get ahead of the curve. But we need to look at where we are now.
Thank you for that question, and I agree with you. It reminds me a little bit of anyone who has celebrated Passover with the 4 questions. And what about the child who isn't wise enough to know the questions to ask? And that is sort of what the root of this bill is we maybe don't know the questions to ask. So to have a comprehensive look of what's coming, we know that these changes that just were signed into law July 4th are now being added on top of long-term plans and strategies that the state has had in place. So this is an attempt to have all of that brought together and have those questions answered in one comprehensive package.
Representative Kesselring.
Thank you, Mr. Chairman. Thank you for taking my question. So on the idea of asking the questions, did you ask the department before or consult with them about this? Because looking at it quickly, it looks like a lot of this is covered under federal requirements when it comes to reporting. So I'm just curious if you had that conversation with them.
I did. I reached out to Mr. Lippman, and we discussed the concept of this bill and his views on it, and what he felt like he had the information on, what he maybe felt like he would be challenged to get the information on. So we did have that exchange. Thanks. Thank you so much. I appreciate it.
Good morning again. Henry Lippman, the state's Medicaid director. In terms of transparency for the legislature and the different uses that you have, it support making sure you have information. Representative Tversky and I did have conversations about things that we do have. The report that was referenced about that the New Hampshire Fiscal Policy Institute just published, a lot of that information came from the department directly so that they could do some work. And there's been some national numbers that have been published on potential coverage losses and other impacts of the reduction in tax and so forth. the number that's out there in terms of the 10-year impact is different than what I think may happen in the next biennium because of the rural healthcare transformation funding. We're potentially able to have money come in to help with adaptation. We received an award of $204 million for potentially 5 years. We have to, that award is contingent on how we execute on the award, but there's close to $1 billion that may come in over the next 5 to 7 years because there's the granting of the money and then the time period to get it all implemented. I think that's a factor that we'll need to get some more information on to see how that's going to help. I think in the short run, some of the things that I think the reason why we have a fiscal note is there's some things in there that are a little bit challenging. For example, quantifying the on item B, C, and F. Those are, if you have the bill in front of you, the exact impact on organizations and access to care. We do monitoring of that, but if we had to do a special study, we use we're required to have a contractor who assesses that, but we got to do an extra study. There's money involved with that, and then the downshift on local communities. Again, that's not something that I feel like I was a city councilor for 9 terms. I do have some sense about how we'd measure that, particularly in the time frame of the bill here. That's without some support is why I think we have a fiscal note. But we want to be transparent in terms of what the impacts are, and so in terms of the concept of the bill, we'd be supportive of that because I think that's the kind of information different committees of jurisdiction would want to know. I think, though, to be realistic, we would need some funding to do certain components of the bill.
Thank you, Mr. Chairman. Welcome back, Mr. Lipton, and thank you for taking my question. My question is, the Rural Transformation Grant is a lot of money. But am I correct in understanding, and if you could explain this a little more for me, my understanding is that that money may not be used to close gaps in services due to budget cuts or other things that have been made, that grant money is to create new ways of dealing with healthcare. And so it's not a stopgap, it's an opportunity going forward, which then will have to be funded beyond the term of the grant, which is why it might be, so the budget implications of that are going to be enormous.
I think I would say that I agree with everything you just laid out there. I would just modify just a little bit that it isn't not intended to save an organization, right? It's intended to, what I describe it as, it will help the healthcare system adapt to the new environment, if you will. And so, for example, gain efficiencies that will help long-term profitability, as opposed to, say, I just had a $500,000 loss and I want $500,000. It isn't going to do that. What it might do is support a better technology investment, training. It could be a number of different factors that will affect the long-term viability of healthcare in rural areas. Staffing is one huge factor that rural communities face. There's also some technology in terms of how care is delivered, but also in pure things like cybersecurity and other things in terms of matching the, if you will, the infrastructure that insurance companies have on providers and being able to line up with that in a way that you're not taking unnecessary losses as a provider. So I think that's where it goes. But I do think one of the other objectives in our application was to look at other financial models for delivering services in rural areas, and that won't happen on day one, but it is part of the plan is to try to make a more sustainable model. The problem with a lot of the models today, they result in what they call share savings. It's just a slow way of reducing the budget in a way that's not sustainable for small rural providers. Trying to come up with a different way to approach that to control the rate of growth in a positive way is, I think, where we need to go. Over the horizon here directed a major portion of how we fund the Met Dish arrangement. We're going to have to find, after this current arrangement's in place, we're going to need to find a different way to make that program work. And so, in terms of some of the impacts, when you look at a final report on July 1st of 27, it'll be final what we know at that time, but I think there'll continue to be reason to continue to report to various committees, particularly Health and Human Service Oversight, what's happening.
You may have one follow-up. Just one follow-up, because I'm thinking about my own area. Are there thoughts in the current or in perhaps the subsequent one, because I know the current plan was put together very quickly, of dealing with the issue of transportation, which in my area is a huge barrier to healthcare, particularly for the elderly or people who don't drive?
The grant application did include trying to make reforms in transportation as well, because that was one of the key issues that not just in your area, other parts of the state had identified as concerns, and how we can make things work more effectively with the resources we have and potentially new resources. But I think transportation is a big issue.
Thank you, Mr. Chair. Thank you for taking my question. I'm sorry if it was already asked, but you mentioned that some information is easier to get than other. So, is there any way to make this bill revenue neutral by removing some items, and what would you recommend removing to make it revenue neutral?
I think maybe an approach is do the best of what you can with the resources you have, as opposed to maybe trying to, rather than taking things out, is just need to be realistic of what you can assess in that time frame on the impacts in those particular areas. But I think the way we approach the fiscal note is that there'd be a deeper expectation, but that I think is a factor into this. But if you were to, the items that I addressed were the ones I think would consume the dollars, but I do think there's something that could be done without necessarily having to go as far as you might otherwise think.
Thank you, Mr. Chair. And thank you for taking my question. Earlier, when you were talking about the Rural Health Transformation Project, and you said it's $204 million, and then it seems like you said something like potentially $1 billion coming in. Can you elaborate on what you mean by that?
Thank you for the question. It's a 5-year grant opportunity. The first year award was $204 million. If we were to receive that same amount for each of the 5 years, it would be over $1 billion. And the way that these grants work is you're kind of rescored every year in terms of what progress you're making. Also, there's time limits on getting the money out the door. And so if you don't meet those, your next award could be smaller.
Follow up? Microphone's on. There you go.
I think these types of questions are, some of them are implied within some of the work that's going to be done, but this type of report doing this type of report isn't in that grant.
Representative McLean.
but as you mentioned, there are some items B, C, and F where you said we're not really equipped to maybe answer that. Nevertheless, there may be value in gathering that information, maybe not. But for a $250,000, do you think that these are some things? When you look at the questions, are you going? Is the impact of having those answers going to be worth the money to you? And the other question that I had is that it looks like the report is due on July 1st of 2027. Given, you're going to get the plan submitted by June of this year, it gets approved, you're not going to really have had a lot of run room. Do you think any report that we might be getting by July of 2027 might show us the landscape, or do you feel it might still just be projection at that point? So just let me go through that.
I think if I can take the last one first, I think you need a longer runway to really get a sense of how these things are going to play through. Not that I would volunteer this per se, but I think in terms of whether the July report ought to be like a final report, or whether you might want to add another future report in there to collect more information. I think in terms of what that would mean to assessing certain things and having a longer window there's a lot of things we as a department, my division, has to do to get everything ready for January 1st of 27. In terms of, I know we don't have a lot of bandwidth to deal with BC and F in the short run particularly. But I think on a longer run standpoint, you can collect some of the data on some of these other issues that will emerge by reporting in different, when you take, for example, the provider one, or you could go to the municipal association and say, what have you seen as impacts? You could go to the various associations to get some sense of what the impacts are versus trying to project what it actually would be. Just an approach that would maybe save some money in terms of how this is approached.
Other questions? Seeing no other questions, thank you.
Thank you.
Also signed up to speak is Christine Stoddard from Bi-State Primary Care Association.
Good morning. If I could have Greg White come with me just in case you have specific
We already have
questions.
a card from Mr. White, so.
Thank
okay.
you.
Great, thank you.
For the record, my name is Christine Stoddard and I work at Bi-State Primary Care Association. We represent New Hampshire's community health centers, the area health education centers, and various consortia throughout the state. We support this bill because we need to know what we're looking at so that we can be prepared. And what Henry said at the end of his comments is really important. We work very well together with our fellow associations. We work with the Hospital Association. We work with substance use disorder treatment providers. But we are siloed in that we collect information that's applicable to our members, not their communities. And so in Greg's case, he has, as he mentioned, he treats patients from 40 different communities. So it's really important to know not only what the impact to his Nashua Health Center is, but what's the impact to the other providers in Nashua. Because without doing that, without having that information, you don't get the full picture. The federally qualified health centers are a terrific network, but they exist all over the state. Would it make sense for different healthcare organizations to consolidate? Would it make sense for them to merge in order to increase access to care? I think that's the kind of information that can come out of looking at, or that can come out of 1794. I would also say that we need to be prepared in that our citizens need to know what's going to happen. as a mom, as a healthcare user, I want to know that my kids are going to have access to care. I want to know that I will have access to care. And I think that we as Granite Staters deserve to know what we're looking at. And I think, you know, Greg operates a business, and I don't want to speak entirely for you, but he is a business. They need to know how they should be planning for the future. And without the state taking a whole state approach, it's not going to give him an accurate picture either.
I don't have anything to add.
Okay, thank you. Any questions? No questions? Wow, okay, thank you. Also signed up to speak is Michelle Lennon from Archways.
Good morning.
Good morning.
Thank you. Good afternoon. Is it morning or afternoon?
No, it's still morning.
Chair and members of the committee. Sorry, I'm a little nervous. My name is Michelle Lennon. I'm the president and CEO of Archways, which we have 4 recovery centers, the community recovery organizations, Plymouth, Tilton, Franklin, and Concord. And then 2 of which are also family resource centers. And then I also pastor a church in Tilton, and we have a food pantry that serves over 500 families, most of whom are supported by Medicaid. And I'm also a family member of someone in recovery who previously relied on Medicaid before transitioning to coverage under Anthem through my employer-sponsored insurance. And most recently, he's bought into the marketplace. So Medicaid touches a lot of the families that both my organization and I touch personally. I'm also on the board of one of the federally qualified healthcare clinics where Medicaid supports 75% of their patient revenue. So this is a big thing with the changes that are happening in Medicaid. So I'm here today to support this bill directing the New Hampshire Department of Health and Human Services to study the impact of Medicaid changes on individuals, specifically because of my concerns for impacts of those affected by substance use disorder. From a professional standpoint, I can tell you that Medicaid is the backbone substance use disorder treatment in our state. The majority of individuals walking through our doors rely on it for access to counseling, residential care, medication-assisted treatment, and recovery supports. And when Medicaid policies change, whether through eligibility shifts, prior authorization requirements, reimbursement adjustments, or other processes, the ripple effects are immediate and measurable on the ground. But generally speaking, it's not measured that way right now. So from a personal standpoint, I've seen how fragile early recovery can be for people and how important that continuity of care is. It's not abstract to me. It's not a policy concept to me. It can mean the difference between stability and recurrence of use, sustaining recovery, or even death. And I experienced this in my personal life because my husband had fallen 40 feet from a roof, and he lived through the fall. Was overprescribed OxyContin 80s back in 2009 when he took a year basically to learn to walk again after the surgeries. He had a disruption in his care when his primary care doctor, Dr. Youngs at Health First, passed away in a house fire. And it obviously a horrible thing, but it was disastrous for his recovery. That interruption in his care led to a reoccurrence of use. He was Narcaned in my home by my son, and we are very lucky that he's in recovery today. So even a small coverage disruption or any disruption can create fear, confusion, gaps in treatment at the worst possible time. And we are expecting there will be gaps as people are impacted by the new requirements. This bill doesn't mandate expansion or reduction of Medicaid. It does not predetermine outcomes. It simply asks the department to provide data so that future decisions are informed by evidence.
If you could start wrapping up, please.
The basic thing is we need to know what are the impacts with these changes and how it is affecting people in the Granite State. and not overlook the fact that these could be life and death impacts.
Thank you. Representative Palazzo.
Most people who enter early in recovery are not capable of working. Usually their executive function is so impacted, they're not in a condition to work. Very often they go to treatment for 30 days, which also prevents any jobs. Usually when we are working with people in early recovery, we help them get jobs that we know they may lose as they learn to work again, basically meeting a clock, showing up to work on time as executive functioning begins to heal. So I'm not sure how it would necessarily impact in a good way.
Follow up.
Yes. That's pretty much how it is now, so I'm not sure how it would change.
Other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Linda Hodgson from AARP. You've asked for 5 minutes. Again, if you could keep it to 3, please. Don't forget to put your microphone on.
Thank you. My name is Linda Hodgson, and I'm a volunteer with AARP. I'm here today to share with you some testimony from Christina Fitzpatrick. She is our state director. So, honorable members of the committee, I submit this testimony on behalf of AARP New Hampshire, which has 215,000 members, in strong support of House Bill 1794. House Bill 1794 is a straightforward, good government bill. It ensures New Hampshire has clear, independent information about how major federal Medicaid changes would affect our residents before the state makes decisions that could impact coverage, costs, or access care. A recent analysis by AARP reveals some significant negative effects on New Hampshire residents that will result from the One Big Beautiful Bill Act. House Bill 1794 would create further analysis to complete the picture. AARP's report shows that Medicaid enrollment in New Hampshire could drop by more than 10% by 2030, meaning roughly 19,000 people losing coverage. The number of uninsured Granite Staters could grow 64%, leaving over 41,000 more people without coverage. State Medicaid funding could decrease by more than $200 million by 2030, with rural areas shouldering a large share of the losses. These changes would ripple through our healthcare system, affecting families, hospitals, mental health providers, and long-term care services. Without solid data, the state could get caught off guard. House Bill 1794 ensures that before New Hampshire acts on any major changes to Medicaid, the state receives a clear analysis of how many people will lose or gain coverage, the impact on state and local budgets, the effect on hospitals and other providers, specific impacts on rural communities and vulnerable populations. This is not a debate about expanding or reducing Medicaid. It is about making decisions based on facts and not assumptions. AARP New Hampshire urges the committee to vote ought to pass on House Bill 1794. This bill gives our state the information it needs to protect residents, plan responsibly, and maintain a stable healthcare system. Thank you for your time.
Thank you. Any questions? Representative Weber?
Thank you so much, Mr. Chairman. Thank you for taking the question. And if this is outside of what you have prepared to look at, just say so.
Okay.
I don't know, put anybody on the spot. But one of the concerns I have is the effects, particularly on our older Americans. Now, many of them are on Medicare rather than Medicaid, but is there crossover? And if so, what are the ramifications?
There is a number of people that are elderly that are on both Medicare and Medicaid. Yes, I don't have the numbers. We can get those for you, or we can try to get those for you. I would take that question back. I don't know that off the top of my head.
Follow up.
So, you identify people in rural areas, but this is a bill that has, am I right in thinking that this is a bill that has the potential, and we don't know what potential is, of affecting older Americans in particular?
Oh, absolutely. Absolutely. And I appreciate your earlier question about transportation, because that is a big issue for the older Americans.
Representative Mazur?
Yes, thank you for taking my question. Did you say that? You don't have to say. Yeah. All right, I keep hearing the mention of drop in coverage. Could that be a result of Medicaid work requirements that are now passing in different laws throughout the country, including Vermont?
I would say yes, but Mike Padmore, who usually is before you as your AARP contact, I can certainly take some of these questions back to him to get you more specific information.
I would have one. Oh, suddenly it's louder. I would have one follow up to the previous question, which is if there is a drop in coverage, and if Mr. Padmore has any further enlightenment for us, could he separate out the difference between people who are not willing to work and the people, although they are capable of it and not under one of the exceptions we've talked about, and the number of people who can work, probably are working, but who will have difficulty dealing with the verification requirements?
Okay.
Thank you.
A gatehouse. So, good morning, Chair and members of the committee, and thank you for the opportunity to testify this morning in support of HB 1794. My name is Jamie Powers, and I currently serve as the Chief Executive Officer of the Gatehouse family of companies located in Nashua and Manchester, and serving clients from all areas of the state. So I want to take you on a little historical trip. I started in this field in 2007 at Phoenix House in Franklin, when there was no Medicaid coverage for substance use disorder treatment services, outside of very limited services for pregnant and parenting women.
and most private insurances would cover only outpatient services, if even those. Our only public funding for such services was through the federal block grant, and that amount was extremely minimal. The result was that there were maybe a dozen providers in the state with extremely limited funding trying to serve the needs of virtually every individual seeking treatment in the state of New Hampshire. One of the programs that we ran at Phoenix House was what was called a social detox. It was intended to be a 7-day program from which people could move on to treatment. But because the residential treatments were so overburdened and people had to come to social detox first, we ended up keeping people for 30 days. That meant when people called us looking for help for a substance use disorder, we had to tell them to wait. Wait 30 days and then you can come in. Needless to say, a lot of people returned to use and added incredible burden to the system as well as to families and communities. Beginning in 2014, we started to see a shift on the federal level with substance use disorder and mental health treatment services being identified as essential benefits and the advent of Medicaid expansion, allowing coverage for far more individuals. I was with the state of New Hampshire at that time and was honored to lead the development of the SUD benefit for the state of New Hampshire's Medicaid program. We developed one of the most comprehensive benefits, and that became available in 2016. That brought the additional funding, allowed existing providers to really expand their services, but also brought new providers into the state. It certainly didn't happen overnight, and the road was not always smooth, but in the end, we now have a system of care where most people with substance use disorders can get the care they need and when they need it. This means a really reduced burden on other systems as well as individuals and families. So today at Gatehouse Treatment and MacCare Clinics, we provide partial hospitalization and intensive outpatient treatment, medication-assisted treatment, recovery, housing for individuals with substance use disorders, as well as psychiatric evaluation, medication management, and transcranial magnetic stimulation therapy to individuals both with and without substance use disorders. As of today, we have roughly 400 lives covered by Medicaid in our care. And that's just my little program. So like so many of us who serve the Medicaid population, I watch the federal Medicaid and federal and state budget proceedings with great trepidation, fearing a return to the bad old days. While that was thankfully not the case, the provisions such as premiums, work requirements, and more frequent revalidation will have a yet to be determined impact on the population. The Medicaid impact study proposed in the legislation is a critical step towards monitoring and responding to how these changes are impacting the Medicaid population. Yep. As well as identifying any positive impacts and maximizing those. I also believe it will reduce, in the long run, burden on criminal justice, uncompensated care, courts, and unemployment. Thank you. Any questions, I'm happy to take.
Thank you, Mr. Chair. Thanks for taking my question. You mentioned the work requirement and more frequent validation under the new system. Can you elaborate a little bit on how that would affect your clients?
Yeah, so frankly, the clients who are in care with us would see less of an impact because we have a case management staff who part of their job is to help the clients to manage those sorts of, showing that they are in treatment, so meet the work requirements, helping them to know when they're up for revalidation, get the paperwork together, and get it in on time. It's folks who are not in care with us, who are out in the community, who don't have resources like that, who are likely to lose their care.
Follow up. Do you have any idea about the numbers of the folks who are out in the community and not under your care who would be affected?
So I don't have the numbers in front of me, and it is a little bit hard to estimate because it also includes, I'm one of dozens now of programs in the state, so I really don't have a great answer for that, no.
Thank you.
Yeah, thank you, Mr. Chair. So You know, and I agree with you. I think that, you know, a lot of the provisions in the OBB are going to impact, you know, Medicaid, and what the nature is of that, we don't know. But this is kind of looking at the information gathering side of that. And I can see how some of these things might be used, but where do you see in your organization this information that's being gathered benefiting, you know, you? Where do you see the benefit in this, you know, extra information is going to come?
Yeah, absolutely. So having, you know, I'm a big fan of data. I like to have all the data at my hands that I can to make decisions. And what this gathering this information will do will help us predict the impacts on our clients and mitigate those ahead of time, as well as to adjust our own business practices and strategies to remain effective.
So, yes, and thank you, Mr. Chair. So, so this is going to be going to the House Clerk, the Senate, but it's also going to be going into the State Library. So, and I'm just kind of wondering, is that the right vehicle? Do you and other organizations often draw on these reports historically to kind of help you make some of these decisions and steer in a certain direction?
So in full disclosure, I've only been with the organization 3.5 years, and only in the CE role for about 2 years. However, I have seen in the past providers utilizing these sorts of reports, and it is certainly something that I would utilize myself for my company.
Thank you.
Thank you.
Mine is.
My mind is not. Sorry.
That's okay.
Sure. But I gather that the
They're
issue was
coming-
whether
kind of like coming on and off.
Mine's working.
Be action.
No, that's
Oh, okay.
Check.
Oh, okay. Thank you. Okay, please proceed.
Thank you. Good morning, Chairman McDonald and Vice Chairman Mazur and members of the Health, Human Services, and Elderly Affairs Committee. My name is Emily Lawrence, and I'm the Advocacy Director with Waypoint. I'm here today to express our support for House Bill 1794 and ask you to vote to pass the bill. Related to my testimony, just to give you a little bit of background about Waypoint. So Waypoint has been in existence for over 175 years, serving children, individuals, and families across the state. We serve people also across the life spectrum, so from birth to death. And we have a number of programs, but two kind of populations that our programs impact that I'd like to talk about today are the Choices for Independence program that we run, as well as the work we do with children. As a provider, we operate Choices for Independence, and we were very happy to have Medicaid rate increases in 2023, and those helped us to increase not only our staff, but our service hours. As we're looking at all of these potential changes that are happening, and even just in the past 6 months as we've been trying to plan our budget for the next year, there's uncertainty. And it makes it difficult to plan. It makes it difficult to plan for staffing and looking at the number of people that we might be able to serve. So having data and information would be extremely helpful. We also work regularly with the department. We try to partner with them as much as we can to assist in working with providers in ways that could be helpful. And so we certainly would be willing to work with them on anything that would be helpful to this report in terms of provider information. The other population that I wanted to talk about is children. So we know that children make up the largest eligibility population for Medicaid, that 1 in 4 children in New Hampshire are on Medicaid or have Medicaid services. And so any changes to Medicaid policy could have direct impacts on them and on their families. These programs provide developmental care, behavioral health care, preventive screenings, early intervention, a number of different programs to help support healthy development. We think that it's important to know what's going to be happening or what is happening in order to ensure that they can maintain continuous coverage, and also for us to be able to, so it's kind of tied together. So the work that we're doing, we need to know as a provider how we're going to be impacted and what could be we could be doing to be nimble to help to continue those services. And then also, as it was already mentioned by a previous speaker, it's really important for families and families and individuals to know if they're going to be impacted. So we would ask you to pass this bill, and I'm happy to take any questions.
Thank you. Any questions? Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. For people on choices for independence, do you accept them and start providing services before their Medicaid application is approved, as do many of our nursing homes?
That's a good question that I actually can't answer, but I can get that answer for you. I think we do now. Yes.
Because I think one of the early changes that I think is being implemented now is that, say, a nursing home that took someone in, they could bill for up to 3 months for care provided while they're waiting for.
Sure.
So that's going down to 30 days. I was just wondering if the Choices for Independence program is likewise affected. I guess I'm trying to think of what early impacts, given the time frame of this bill,
that we might see.
Yeah.
I can certainly talk with our CEO and get back to you with that, some information about that, for sure.
Okay. Thank you. Anyone else? Okay. Thank you.
And I also have written testimony with a little bit more information.
The clerk is very grateful for written testimony.
Anyone with written testimony, I'm happy to.
Also signed up to speak is Sam Burgess from New Futures.
Thank you, Chair McDonald and members of the committee. Again, Sam Burgess from New Futures. I know it's been a long morning, so I will keep my testimony to 2 points. First point I'd like to make is that New Hampshire cannot responsibly implement additional Medicaid changes without understanding who is losing coverage, why they are losing it, and what happens to them afterward. HB 1794 gives us the data we need to prevent avoidable coverage losses, which are a real concern. During the Medicaid unwinding process, approximately 70% of disenrollments nationwide were due to procedural or administrative reasons, such as failing to return renewal paperwork or having outdated contact information, rather than a confirmed loss of eligibility. Without clear state-specific data, New Hampshire risks repeating those avoidable losses, especially amongst children, people with disability, and working adults who rely on Granite Advantage. HB 1794 ensures that we can fully understand how Medicaid changes are affecting coverage, access to care, and the stability of our provider networks. This bill gives you, the policymakers, the information you need to intervene before small administrative problems turn into large-scale coverage disruptions. The second point I'd like to make is that this information is also important because reductions in federal Medicaid funding create real financial risk for New Hampshire. With the federal government covering half of traditional Medicaid costs in our state, even small federal changes have outside consequences for us. National projections show more than $911 billion in federal Medicaid cuts over the next decade, and states that have already experienced reductions saw higher county and municipal spending, especially in behavioral health and emergency services. New Hampshire is not immune. As the sponsor noted at the beginning of this hearing, we've already seen provider strain and even closures tied to Medicaid funding shifts. Amanuense Community Health Services closed its Franconia, New Hampshire location late last year, which impacted more than 1,400 patients who regularly frequented that clinic due to roughly $524,000 in revenue lost from Medicaid cuts. Add to that budgetary strains from uncompensated care, which ultimately show up in state and county budgets, provider strain leading to service reduction and closures, lost revenue from cuts to the Medicaid enhancement tax, and cuts to Granite Advantage, which are going to hit New Hampshire especially hard. Without a clear analysis like what HB 1794 proposes, the legislature risks making decisions without understanding the downstream financial impacts in light of federal changes. This bill is a fiscally responsible step to understand those impacts before they hit taxpayers. And for those reasons, we ask you vote ought to pass on HB 1794. Thank you.
Thank you. Any questions? Oh, Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, and I agree that gathering the data is good. My concern is, in a very tight budget, I had bills of my own that were killed for less than $250,000, and so that amount of money is very precious money. And so I'm just wondering, when I'm looking at something like B, where we're looking at the impact on nonprofit healthcare organizations, I'm thinking that's data that's going to be gathered by the Hospital Association. When I look at F, which is something else that Director Lippman said I don't have access to, but the Municipal Association is definitely going to have access to that. And they have an open forum here where they're going to be able to come in and present that and say, we're really getting hammered at the municipal level, at the county level. So I'm just wondering what it is that the $250,000, which is very precious money, is going to buy when the Hospital Association, they're very vocal. They'll be here. The Municipal Association, they'll be here. And that's I guess where I'm struggling. So I'm just wondering, how do you put that together?
Thank you for the question. I think it's a really good question. And I think I would refer back to the testimony of the sponsor as well as the testimony from Bi-State. And that is, I think putting everything together in the aggregate gives us the bigger picture, right? So it is certainly a large amount of money. $250,000 is not nothing. But looking at the $911 billion nationwide that we're going to lose in Medicaid funding due to the One Big Beautiful Bill Act, and we're certainly going to have our fair share of those cuts here in New Hampshire. We need to know, looking down the road, what's coming our way, where these cuts are going to hit us, so that we're not going to have large amounts of disenrollment due to administrative hurdles that we could have otherwise predicted and cut off. I think that $250,000 is truly going to snowball into giving us real perspective as to ensuring that we don't have a lot of people losing coverage, going to their local critical access care hospital, going to the local FQHC, and creating new uncompensated care. I think fiscally it makes a lot of sense and puts us in a good position to ensure that we know where these impacts are going to hit, know what communities they're going to hit, and are ready and prepared to absorb those costs and put those resources where they're needed.
Thank you.
Anyone else? Thank you. Also signed up to speak is Holly Stevens from NAMI of New Hampshire. And you have written testimony. Thank you.
Mm-hmm.
Chairman McDonald and members of the committee, thank you for the opportunity to testify this morning. My name is Holly Stevens. I'm the Director of Public Policy at NAMI New Hampshire, the National Alliance on Mental Illness. On behalf of NAMI New Hampshire, I am here to speak in support of House Bill 1794. Here in New Hampshire and throughout the country, as you've heard, the healthcare landscape is changing rapidly, especially for those covered by state Medicaid expansion programs. Between the federal One Big Beautiful Bill Act and the 2026-2027 New Hampshire budget, individuals and families
have been faced with confusion and uncertainty amidst significant, duplicative, and sometimes contradictory policies impacting Medicaid eligibility and cost sharing. Over the past year, we have heard repeatedly panic and confusion from Granite Staters we serve. Time and again, our community has shared their fears that they may lose access to the services that keep them and their families well. Access to health coverage is essential for people with mental illness to successfully manage their condition and achieve long-term recovery. When people have access to the care they need, when and where they need it, fewer people end up homeless, hospitalized, and incarcerated. Easy access to affordable health care is critical to the health and well-being of all Granite Staters and often prevents the need for costly higher levels of care. As the largest payer of mental health and substance use disorder services, Medicaid provides access to critical services like psychotherapy, inpatient treatment, prescription medications, crisis care, and more. Policies that increase the cost and burden on Medicaid beneficiaries or create barriers to coverage disproportionately harm individuals with mental illness and substance use disorder. In the coming years, the state will be working to understand the impact of all of these changes that you've heard about. And House Bill 1794 would start that work now. This bill does not reverse the changes or provide solutions to those who will be impacted by the changes. It's a crucial first step for the state to prepare and address the impacts of the changes. And it would give organizations like NAMI New Hampshire the data that we can then push out to the people that we're hearing from that are terrified right now that they're going to lose their coverage. We've heard from people who are on traditional Medicaid that think Medicaid work requirements are going to apply to them. And they don't understand how they can work enough but not lose their disability. And we have to explain it doesn't apply to you. It only applies to the Medicaid expansion program. And data like this is going to be critical for us to be able to talk with our folks so that we can better inform them and alleviate their fears and concerns. And with that, I will take any questions.
Thank you. Any questions? Seeing no questions, thank you.
Thank you.
Also signed up to speak is Jonathan Ruthier from New Hampshire Community Behavioral Health Association. And he also has written testimony, Madam Clerk.
Wow, this is awesome.
Good morning.
Good morning, Chairman McDonald and members of the committee. Thanks for hearing our testimony today on this bill. Copies of my testimony are coming around for all of the committee members. My name is Jonathan Ruthier. I'm the Executive Vice President for the Mental Health Center of Greater Manchester. And I'm here representing the New Hampshire Community Behavioral Health Association, which is comprised of the 10 community mental health centers in New Hampshire. And I'm testifying today in support of HB 1794. So the objective of this bill is not only to identify, but to understand the impact of changes in the Medicaid program to New Hampshire's citizens and providers, as well as potential impact on the state budget. This bill is of particular importance to the community mental health centers who endured significant operating losses following the Medicaid unwind at the end of the COVID-19 public health emergency. Those losses were incurred as a result of two conditions. One, the disenrollment of those who retained coverage during the public health emergency and who were either no longer eligible for Medicaid or failed to redetermine eligibility. And two, our legislated mandate to serve all persons eligible for community mental health services regardless of their ability to pay. Those two factors combined to increase the amount of uncompensated care across our system to a number of roughly $19 million in fiscal 24. We are understandably in the position of not wanting to repeat that experience, and we want to make sure that there is a resource to help the Department of Health and Human Services plan accordingly so that we can learn from our experience. As we stand today, the community mental health centers are working collaboratively on a number of initiatives, including addressing our longstanding workforce challenges so that we can continue to address the mental health needs of New Hampshire residents. But it's safe to say that if a large number of individuals we serve no longer have the ability to pay for those services, our efforts will be seriously undermined. Passage of HB 1794 will provide DHHS with the direction and resource needed to understand the impact of changes to Medicaid, and more importantly, to allow for careful planning that is informed by all Medicaid stakeholders. And on behalf of our association members, I ask that you vote on to pass on 1794.
Okay, thank you. Any questions? Seeing no questions, thank you very much.
Thank you.
No one else has signed up to speak on this bill. Does anyone else wish to speak on HB 1794 FN? If no one else wishes to speak, I'm going to close the public hearing on this bill and open the public hearing on HB 1070-FN. And I was just about to ask Representative Lucas or Representative McGrath to do that, so thank you, Representative Lucas. There you go. Thank you. I appreciate it. Okay, again, I'm going to now hear, I'm opening the public hearing on HB 1070 FN, and I will recognize the prime sponsor, Representative Dennis Mannion from Rockingham County District 25. Good morning.
Good morning, thank you. I see everyone leaving. I didn't know if that was me or not.
I don't think so.
Okay, good.
It's been a long morning.
Thank you, Mr. Chairman, members of the committee. Representative Dennis Mannion, I represent Rockingham 25, which is Salem. This is a simple bill. Just for some background, I've been in law enforcement for 30 years. I've worked for a couple different agencies. In some agencies, ambulance would have no problem transporting somebody for involuntary emergency admissions. Some agencies, the fire department refuses to do it. They interpret the law a little different than what it really says. So what this bill does is, under current law, individuals in protective custody for an apparent mental illness and immediate danger are often transported solely by law enforcement to an emergency room or designated site for an evaluation. This can heighten tensions, risk escalation, and place unnecessary strain on officers and the individuals in distress. HB 1070's key provisions are in proposed RSA 135C28-4 shifts the default to ambulance transport under the care of an EMT. This prioritizes medical expertise during transport, supports better de-escalation, and aligns best practices for behavioral health emergencies, where trained EMS personnel can assess and manage acute needs more safely and compassionately. The bill wisely preserves flexibility. Consent is not required during these things, so if a law enforcement officer determines that there's a safety risk to the EMTs, police transport shall remain an option. This targeted change promotes safer, more humane crisis intervention without overhauling the system or adding major costs. It complements ongoing efforts to enhance community mental health responses. I respectfully ask that you support HB 1070 and make our protective custody process more effective and person-centered. And I will try to answer questions if you have any.
Okay, thank you. Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. And just if you have the answer, I seem to recall having had a pretty in-depth and nuanced conversation about this very issue maybe 2 or possibly 4 years ago. It begins to blur. And I'm wondering, did that bill simply not go on to pass, or is this a further revision, if you know?
I do not know anything about the other bill. This is a simple revision that was brought to my attention by a local police chief, so that way we can, it helps with our resources, but the most importantly, it doesn't stigmatize people who are looking for assistance being put into a police car unless it's absolutely necessary. So this basically, it just makes ambulance the first option. And this is only for the initial transport to the emergency room for the evaluation. If they're certified, that's done by a law enforcement officer to whatever facility they're placed. So there's 2 separate things going on here. This is just that initial from the home or wherever the officer runs into them from the IEA application for the evaluation at the hospital. This is not after they're certified, which is done by law enforcement.
Follow-up?
I just want to say thank you, because that has clarified for me what the difference is. The bill that we had was the transport from the emergency room onwards.
To the
So
facility,
thank you
yes.
very much.
That stays intact.
Okay, any, Representative Drew?
Thank you, Mr. Chair. So I'll ask the obvious question, who pays for the ambulance ride? Because if this person is being put in an ambulance without their consent, then are they expected to pay for it?
I don't have that answer. I imagine there might be an insurance policy, or I'm not sure who does it. It's currently being done, just so you know. A lot of times in my career, ambulances always transported them. So I imagine that cost issue has already been worked out, but I don't have the answer as to who would ultimately be responsible. I would think it would be the person or their insurance company.
Other questions? Oh, Representative Woods.
Thank you, Mr. Chair. Thanks for taking my question. Just for clarity, and I may just not understood what's occurred in the past, so help me out. If someone is needing this level of care for evaluation, and they're not a danger, they should go to an ambulance according to this bill.
Yes, so not necessarily not a danger. They could be a danger to themselves. There has to be some criteria for them to have an IEA against them.
Okay.
Danger to themselves or somebody else. So if they're not a danger to the EMTs or anyone else, just to themselves, they're suicidal or whatnot, that's where this would take place, where an ambulance would be a better suited transportation than a police car.
Okay. Well, then if they're, I'm sorry.
It's okay.
Follow up. So if they're agitated, does the ambulance driver say, "No, I don't feel comfortable. I just don't feel comfortable taking this individual"?
Yeah. So I guess that discussion could be had. The law enforcement officer would be the one to determine whether or not they're a danger.
Yeah, because it doesn't state here who makes that decision. I'm sorry. Follow up. I'm sorry.
Line 18.
Representative Weber is coaching you.
Yeah, coaching.
Line 18, it does say that the law enforcement officer, if he deems it a safety risk, will transport the person.
Okay, I'm sorry.
No problem.
Other questions? Representative Drew.
Thank you, Mr. Chair. You had talked a moment ago about different interpretations of the existing law. Talk more about that. What is the existing law? You said that ambulances typically do this in your career, in your experience. They do this. Why are other people making different choices, and what are they basing that decision on?
They're basing the decision on the second part of the law, which says after certified, transportation is done by law enforcement from the hospital to whatever facility they're going to, the state hospital or wherever judge deems that they're going to go to. The first part of it is the part where it isn't clear that it's law enforcement or an ambulance or any other means of transportation. So there are some fire departments that are interpreting the first part from the location to the evaluation as must be by law enforcement, but that's not the case. So this just clarifies that. The second part stays the same. It will be law enforcement after certification.
Other questions? Take no other questions. Thank you.
Thank you.
Also signed up to speak is Sheriff Bill Wright from Belknap County.
Thank you, Chairman McDonald and members of this committee. I am Sheriff Bill Wright. I am currently the Sheriff of Belknap County. I'm in my third term, and I have 28 years law enforcement experience here in the state of New Hampshire, all full-time, between city, town, and county. I'm here to testify in opposition to this bill. The Sheriff's offices, I'm sure that you know, perform a lot of these transports to and from the hospital and to and from some of the other facilities around the state. Right now, when a law enforcement officer is called to a residence where somebody's in mental health crisis, at that point, they have an opportunity to be transported to the hospital for a mental health evaluation, either by ambulance or by sheriff's office or police officer at their choosing. That is normally called voluntary. Anytime that a person is going to do harm to themselves and they choose not to go up to the hospital to be evaluated, and we believe that they're going to take a substantial step to harm themselves or others, then we will take them into custody, and it will be the involuntary as written in this law here. Traditionally, a person that is in involuntary status, traditionally law enforcement will do the transport because the person is in that crisis where they can no longer make that decision to go up to the hospital on their own. So as a safety measure, we do the transports for those people, and we appropriately restrain those people and bring them into a facility where they can be appropriately addressed at that time. Anytime that a person is being transferred, if during their evaluation process at the hospital and paperwork is drafted to where they need to be transported to a receiving facility, designated receiving facility, such as New Hampshire State Hospital, at that point, the hospitals have the ability to either have them transported by ambulance or by sheriff's office vehicle, which traditionally around the state we're finding that sheriff's office vehicles are predominantly utilized because it's taking the resources of the ambulance crew away from their community for extended periods of time. Not to mention that we do the transports quite frequently with 1 or 2 deputies in one vehicle, and most of the time we're on. It happens at night, and we're off duty anyways, so we get called in to do these transports. So really the resources being utilized a little bit better. So because of that, I'm in opposition to this bill, that I believe that right now for involuntary matters, people do have the choice to go, or voluntarily, they get to go to the hospital in either an ambulance or a police vehicle. When it comes to involuntary, if I need an ambulance to do the transport for whatever reason, if they have some type of injuries or things like that, they can still do the transport, but we will accompany them, and that's for the safety of those who are riding in the ambulance. This is not about an inhumane thing. It's about safety to the person that's being transported. It's about safety of those who are actually doing the transport of these people and the receiving facility in which they're going to, which we're most equipped to do so. And I will take questions.
Thank you. Any questions? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. I'm still struggling to understand the whole spectrum. The prime sponsor said that different municipalities do it differently, and that one of the goals of this legislation is actually to clarify who is transporting in this situation. So I understand that you think that law enforcement should be involved in transportation in these situations. So do you think that we need to clarify current law, but not in the way the sponsor suggested here?
Well, I believe that, thank you for your question. I believe that as law enforcement, if we're involuntarily committing somebody and bringing them to the hospital, that should be done by those professionals who have restraints and things that help keep people safe. So that's normally a law enforcement. Where ambulance service doesn't provide the same level of protection that we do. We have protective gear, and this is what we deal with. We deal with people in crisis, and again, we deliver people to where they need to go to get the help. And I believe that asking or telling, because I believe that this bill is designed to basically tell the fire departments that they'll be doing the transports. And unless we determine as law enforcement that they should go with us, then we're putting it all onto the fire departments to make, to mandate them to do it. I'm not so sure that is exactly what we should be doing to transport these people. In some of these places that are transporting for long distances, they don't have secure vehicles. I drive around with a vehicle that has a cage in it, and when I say cage, it's got a barrier in the front and a barrier in the back, and of course it's got barriers on the windows. So the ability for somebody to kick out a window or to do things, again, they're in mental crisis. If they're involuntary, there's a crisis going on, and they're not thinking rationally. That's why we're involved in the situation. So we are more equipped for that. An ambulance does not have that. They have doors and they have one person in the back maybe, and again, they're transferring them from one facility or one location to another that could be an extended period of time in an ambulance. I don't believe that that's the appropriate place for it. I believe that law enforcement is a key component on this. And again, if the ambulance needs to be utilized because of some disability or something, then of course we still have that ability to call upon them to assist us. And but that's, hopefully that answers your question.
Would it be fair to say then that you think law enforcement should have a more proactive role in making this decision, or is that another way to look at it? Or
Yes, I mean, there's nothing that requires law enforcement to actually go to these calls. So there's no legislation in place that requires law enforcement to stop somebody from hurting themselves. So when an ambulance call comes in for somebody in crisis, it doesn't, it can come in as some type of mental health situation. That law enforcement organization, in their policies that are developed within those, there's over 240 police departments in the state, and each one has a police chief, so they make their own determinations on how they're going to respond to these things. So some departments don't even work at night or during the day or what have you. They don't even send people to these unless they're called upon. So you may not even get a law enforcement officer to respond to some of these crisis calls unless the fire department specifically requests them. So so for us to make that determination, we would not be able to make the determination if we didn't arrive on scene. So if we're not mandated to go to these scenes, then how could we ever make the decision that we're requiring them to ride with us? Because, I think that's where it starts becoming disconnected. Okay. Again, our goal is to try to get people to want to go to the hospital and want to seek out that help. So we're willing to say, hey, why don't we give you a ride up to the hospital and go voluntary? But this particular bill is all about involuntary. So it's people who do not want to go, people who are not able to make those decisions on their own to seek the help. So we are required to inject ourselves into their situation and bring them to a place where they can hopefully become restored.
Okay, thank you. Representative Weber.
So I had one question, but if I may, Mr. Chairman, I now have two questions.
Sure.
My first question was that I'm looking at the language on line 17 and 18, and you testified earlier that there are times when, because of a medical reason, the patient is transported by ambulance because that's necessary, but a law enforcement officer may ride along because that's necessary for safety, both for the patient and the ambulance personnel. Am I right in thinking that as this is written, that would bar that? Because what they're saying here is if law enforcement says the individual is a safety risk, law enforcement is going to do the transport. So that would bar the ambulance and the ride along?
Well, thank you for the question. And I would say that no, it doesn't necessarily bar it. It doesn't say that we can't ride with the ambulance. It doesn't say, it would just mean that ultimately we would be the ones, well, it says shall be transported by law enforcement. So yes, in essence, that would prohibit, based on this exact writing, I believe that means that I would have to take this person in my cruiser.
Yeah. And so then that, if I may have the second one. The second question was that your answer to Representative Palazzo's question confused me a bit, because it sounded to me like you were saying, well, sometimes law enforcement isn't involved at all. So could you explain to us a little bit more about how law enforcement specifically gets to the scene, and whether these calls are most typically answered by ambulance personnel or by law enforcement?
I can only speak in reference to my geographic area, which is Belknap County, so Laconia and surrounding areas. What I can tell you is we have 10 municipal police departments within our county, and with that, for every medical call that comes in, whether it be it could be a mental crisis type call, the police are traditionally dispatched to that as well. And in our municipality area, law enforcement will go to those calls. A lot of times, the fire department will actually stage and wait for the law enforcement to arrive first to render the scene safe. So in our geographical area, our law enforcement personnel do arrive, and we do mitigate the scene most of the time prior to the fire department actually getting there.
That's very helpful.
Okay.
Anyone else? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So it sounds like law enforcement are the people making the determination that this is going to be an involuntary transport. So I guess I'm a little bit confused. When the prime sponsor was up, apparently there are jurisdictions where that is not the case, and this just happens through an ambulance. So are you in discussion with people in those jurisdictions? Because I'm just trying to figure out the disconnect in my head between the two.
Sure. I honestly don't know the reasoning behind this bill. Like, I'm the president of the Sheriff's Association, and we do transports quite frequent. So this generation of this bill was not brought to my group to have a conversation about like the legislative intent behind it or what is going on within the state. I can only speak for what's being reported by the sheriffs. When we got notified of this bill in today's hearing, we had several sheriffs respond back that people normally, if we get dispatched to a scene, there's normally two ways of handling situations. One is getting people to go voluntarily, which traditionally they'll either go in an ambulance willingly, no restraints, no anything. They just get into the back, they say they need help, and they get transported up to the hospital. There's other times that we will say, hey, we'll just give them a ride up. And again, we open up the door, they get in the back, we give them a ride up. There's no issues, and we deliver them to the hospital. It's a ride. This particular bill that talks about involuntary admissions, which means it's involuntary. They don't get to make the choice if they're going or not. A government entity, law enforcement, a hospital, the ambulance service, fire department, we're the ones that make that determination. Even a mental health facility, a counseling place can make that decision, and they do a prayer and complaint, and it gets court ordered. We would be required to pick these people up and bring them involuntarily, so they can't say no. So if we're ordered to do it, because there's times that the courts will order us to do it, there's times that the hospitals will sign on the physician's notes that they have to be transported by sheriff's office. That's when we show up. We get called in the middle of the night and do the transports. So that can happen. We do try to get people, I know that there's been bills in the past that have tried to get, people don't like us putting restraints on people that are looking for help, or people that are not able to care for themselves and they need help. But we put restraints on for the safety of everyone, so we can manage people. And that's kind of our business and why we do it. Now, we don't handcuff people in the back and transport them for long distances. We handcuff them in the front, and we have belly belts and things that we use that are a lot more comfortable. And again, we do long distance transports. So when you talk about sheriff's transports, that's exactly what we do. We transport these people for extended periods of time, and we treat them as humanely as possible, and we get them to seek their help, and we explain, that you do have to wear these handcuffs, and we're sorry, and but it's what we have to do, and it keeps everybody safe, and we have our processes in doing it. This is not an on the side of the road, scuffle fight in trying to get somebody in handcuffs and throw them in the back of our car to get, them to a secure location. This is completely different. This is more, we have the situation controlled, and we're doing the transports accordingly.
So
follow up?
Yes, sir. But what I think what the bill does, though, is it says in a case of like a mental illness where the involuntary involves a mental illness, then you're going to incorporate the ambulance, but I don't think it precludes the inclusion of the the law enforcement officer for security purposes, but it does say that if the ambulance crew feels they're not safe, then okay, no, we can just pass it off. So does that not kind of fulfill some of the de-escalation element that the prime sponsor was looking for?
I'm not so sure because line 13 through 19, it says when a person is transported to the emergency room of a licensed general hospital or to another site designated by the community mental health program serving the area for compulsory mental health evaluation of this section, the person shall be transported by ambulance and shall be subject to the care of emergency medical technicians.
Okay.
There's no may. It doesn't say will. Doesn't say should. It says shall. That in law enforcement world, that means this is exactly what you will do, and you have no other choice. Now, there is a little exception where it says the individual's consent to transport by ambulance shall not be required, which involuntary is not required anyways. It's involuntary. That's why we're doing it. Provided, however, that if law enforcement deems that the individual to be a safety risk to emergency medical personnel, the individual shall be transported by law enforcement. This doesn't give a firefighter the ability to tell me I need to do the transport because they don't feel safe. I don't see any provision in this that says that. It specifically says that they will do it, and unless I deem that this person might be a risk, they're doing it. So, at the advantage of a police department that doesn't want to do the transport, maybe that's great language. I don't think it's good language for us. In law enforcement, my job is protection, and I think that's exactly what we do with good legislation, that when we're doing the transports, and we're law enforcement, this is exactly what we do. We protect people against themselves and others. So I think that we should be the ones doing the transports, and in that unless people want to go voluntarily and the situation's different, those are people who can think a little more logically and can get themselves to the hospital. They want the help. And, again, we had situations where we've had potential volatile people who we've dealt with in the past that have a history, got off their medication regimen and started becoming a little more of a danger. Their family understood and recognized what was going on, so they called for assistance. We were able to again get the ambulance to do the transport, but we've gone in tow. So we followed behind them. In the event that something triggered the person and caused an incident within the ambulance, they could easily stop and we could come in and inject ourselves at that point. But they roll up to the ambulance, up to the ER, into the ambulance bay, and the person's offloaded, and we just continue on our business without any further contact. So that type of stuff does happen, but that's normally in an involuntary situation. That's in a voluntary situation. The involuntary is different. They have no choice. So it becomes a little more, we're having to inject ourselves into that because people don't want to have this treatment done. They don't want to go to the hospital.
All right, thanks for the clarification.
Thank you, Representative Weber.
Thank you. And your answer to that answered yet another question of mine. But the fourth question is, you spoke earlier about transport under court orders. But when you are doing the very initial transport, taking somebody from the residence or the street or wherever the disturbance is occurring to a place where they're evaluated, you don't have a court order then, do you, even when it's involuntary?
No. So the involuntary part, when we're on the scene of a call that we just got called to, that's traditionally, it becomes involuntary when we have developed probable cause to believe a person is going to hurt themselves or others,
right,
and that they're a danger to society and so on and so forth. Then it becomes, and we ask them, will you go up to the hospital and talk to the mental health personnel up there and so on and so forth. When they say no, and we believe that we're not going to be able to leave and that it won't be a problem after we leave, if we take them into custody at that point, it becomes involuntary.
Right.
And that's when we would actually, put them into the handcuffs and put them in our cars and do the transport.
But just to be perfectly clear, that's not yet under a court order. That's because of the present danger, both to either to themselves or to other
Correct.
members
It's
of the
actually
community.
pre-evaluation.
Yeah, thank you.
Other questions? Seeing no other questions, thank you.
Thank you.
Also signed up to speak, and she's already walking around, is Holly Stevens from Namahaven, New Hampshire. I didn't want you to go sit down and have to get right up again.
Good morning still, Chairman McDonald and members of the committee. My name is Holly Stevens. I'm the Director of Public Policy at NAMI, New Hampshire, the National Alliance on Mental Illness. We are here speaking in favor of House Bill 1070 today. Though transport within an ambulance is permitted under the current law, far too often we hear of individuals in mental health crisis who are needlessly placed in wrist and ankle shackles and transported to and from the hospital in a law enforcement vehicle. People with mental health conditions deserve help, not handcuffs. Though a person in a mental health crisis may meet criteria for an evaluation or even an involuntary emergency admission, the risk may not rise to the severity that would require such practices that contribute to trauma for the individual and stigma that prevents people from seeking help. Ambulance transport is the most humane way to transport a person in need of care and should be required unless it is deemed unsafe by law enforcement. It should also be noted that a mental health emergency is the only kind of health emergency where law enforcement rather than an ambulance is used to transport. However, we do recognize the cost, as it was brought up by one of the representatives, to the individual associated with being transported in an ambulance, and the stress that financial burden may cause. When discussing the bill with our community members, we heard individuals share that they would prefer a choice in their mode of transport. Therefore, we do support the bill, but we would request that an amendment be adopted making a minor change on page 1, line 17 of the bill. After the word technician, we would suggest adding, unless the person being transported for the compulsory mental health evaluation requests to be transported by law enforcement. Therefore, we would request that you use careful consideration with this bill. And I did want to mention that just because somebody is going for a compulsory mental health examination, that does not mean that they will not go to that compulsory mental health examination. They may not want to be hospitalized. They may not want to go to the hospital. But I worked as a crisis worker in Maine for 9 years. And I talked to a lot of people who said to me, I'm not going to the hospital. I don't want to go to the hospital. And I would say, but we don't have a choice here. You need the help. You need to go. You are a danger to yourself. And I would say we can either do this the hard way or we can do this the easy way. We can go by ambulance or we can go by the police, whichever you want. And most of those times they would choose to go by ambulance. Or I would drive them because they weren't, even though they were going involuntarily and they knew they were going involuntarily, they were not aggressive and they were not combative. And for that reason, we would request careful consideration of this bill because we do support the humane treatment of folks with mental illness.
Thank you. Any questions? Representative Polazov.
Thank you, Mr. Chair. I guess I have a few questions, but my main question is what kind of situations we are talking here, and who should give consent, and if a person is in mental crisis, if they're able to actually provide consent here and make decision who will be transporting them. And it seems like the risks involved in both situations. You mentioned some trauma of being restrained, but also there were discussion about risks to others, but also the person himself, if somebody is being in crisis in ambulance with windows that could be broken or doors that could be open. So could you paint a bigger picture here?
In an ambulance, they do have the option of chemical restraints. They usually, in my experience in Maine anyway, and I can't talk about the experience of an ambulance here in New Hampshire, but they would always carry Haldol, an Ativan, or other benzodiazepines on the ambulance. And if they need it, they would chemically restrain the individual in the ambulance itself. We believe that most people if given the option of a chemical restraint or a mechanical restraint, and most times would opt for the chemical restraint instead of the mechanical. And like I said, most of the people that were going to the ambulance, those who were agitated and combative, and we knew were going to potentially cause harm to somebody, we would absolutely call the sheriff's department or the local PD and say, can you help us here? But that wasn't most of the individuals that I met with and that I talked with and that I ended up what we call the Maine blue papering. We call here in New Hampshire IEA. Most of the people would go along with you. They were calm, they were collected. They didn't want to go, but they said, you know what? I understand you're making the choice for me here. So I think that, you know, because of that, and the data, I notice you're looking at the data that I included was the data for the law change in 2019 that Representative Weber brought up. There was a change that allowed for ambulance transport from the hospital to the designated receiving facility. And I wanted to point out that in most of those cases, even though it is an option to transport by ambulance, and the doctors have the option of chemically restraining that person to safely go by ambulance, over 50% of the cases are still transported by sheriff in shackles. And I don't know why, but we get this data. It's shared with HHS oversight periodically. And it was the reason for that change in the law was to have a decrease in the number of people being transported in shackles by law enforcement from the ER to the designated receiving facility. And I'm not sure that it's had much of a change in the culture that we have in New Hampshire about transporting individuals in mental health crisis by police.
Follow up. Thank you, Mr. Chair. Thank you for taking my follow-up. So my other question is, like, General, I'm still a little bit confused what's going on in different towns and cities. Do we have like variety in New Hampshire that different municipalities do it differently? And also, like, what exactly is mandated? Do you agree that law enforcement presence is not mandated by law, but they typically are present there anyway to when a call comes about mental disturbance?
And unfortunately, I've never done mental health crisis work in New Hampshire. I came here to go to law school and do this work now, so I don't know. But I'm happy to talk with the mental health centers and get that information and see if I can get it to you to see what the practice is for the mobile crisis workers that go out on these calls and evaluate these individuals.
Anyone else? Okay, thank you.
Thank you very much.
Also signed up to speak is Chris Daywas from the New Hampshire Ambulance Association.
Good, almost afternoon.
Still good morning.
Just checking. Good morning, members of the committee. Thank you for allowing me to speak today. My name is Chris Daywas. I have been an AMI registered paramedic for 41 years now. I work for American Medical Response here in New Hampshire, and I'm also on the board of directors for the New Hampshire Ambulance Association. We are here today to speak in opposition to this bill. I've actually become more confused about it since hearing all of the testimony, and I would like to offer that perhaps going forward it would be good to carry it over and allow the stakeholders that are going to be impacted by this bill to determine what's going to be the best course of action so that not only do the patients remain safe, but the caregivers remain safe as well. I've heard, and I'm making notes from where I went here originally to where we are now, our biggest concern in the ambulance world is an elopement risk of a patient who is in an involuntary protective custody situation, which means that they don't want to be there. They don't want to go to the hospital. It is not in the scope of practice of an EMS provider to chemically restrain somebody so that we can go against their will when there are other opportunities to get them where they need to be. Chemical restraint is a very complex and, quite frankly, dangerous thing to do for a human being. And if we don't have to do it, we absolutely do not want to do that. My biggest challenge with this bill is the word shall go in an ambulance. I don't think that that word belongs there. I don't know what word I would suggest to use. But I would also note that the bill that recently passed last year, Senate Bill 425, which talks about reimbursement for ambulance, also requires a ground ambulance service financing and delivery system committee to be established, which is being formed right now. And this may be a perfect thing under that purview for them to examine to see what would be the most appropriate and patient-centered approach so that we are utilizing resources in the best fashion possible, keeping our patients safe and getting them the care that they need.
Okay, thank you. Any questions? Representative Palazzo.
Thank you, Mr. Chair, and thank you for your testimony and explaining us that chemical restraint also have some side effects, but how does it all start? So, what is being signs that person needs to be restrained in some way? So basically, yeah. If you want to comment, maybe it's not relevant here.
I'm not quite sure I understand the question.
You want to clarify?
I'm withdrawing.
Thank you, Representative Mazur.
Yes. Thank you for taking my question. Because I'm reading the analysis of the bill, and it says this bill provides that an individual may be transported by ambulance, but then line 7 says under this shall be. So the may in the analysis switches to the shall in the body. Is that how you are reading it too?
Thank you for the question. Yes, and as the sheriff pointed out, shall is a very
mandate,
black and white word that legally you must follow. And we take people to the hospital that are in mental health crisis all the time and work with mental health crews that are on the street all the time, every day, probably happening right now. The difference is those folks are voluntary. This is involuntary. It's actually in the scope of mental health work that we do, it's actually quite rare. And it's something that needs to be done in a very well thought out and defined way so that everyone involved, particularly the patient, is safe, respected, and gets the care that they need. I just don't think that this bill, as it stands today, is going to improve any of those outcomes.
Anyway, Representative Weber.
Thank you. So, could you clarify your position for me? Is it your position that this really, I mean, I heard you say that this needs more study and might well be referred to a commission being set up under another statute, but would you do you think that this is an issue from your perspective that needs further study, or is this something that from your perspective is working okay as it is?
Thank you for the question. Until yesterday, I wasn't even aware there was a problem that this bill was here. So, and we do. I'm going to say that we do the organization I work for does the lion's share of ambulance transports in the state of New Hampshire for 911 services, and we work seamlessly with the organizations that are out there providing mental health services and law enforcement. I'm also a member, one of the 3 public members of the New Hampshire Police Standards and Training Council, and I've not heard it as an issue in those areas that I work with there either. So,
Could I have one
Follow-
follow-up?
Sure.
So if we were to add the language, and I'm not sure I wrote this down completely perfectly, but if we were to add the language that was suggested by Ms. Stevens, which would be, make it read, the person shall be transported by ambulance and shall be subjected to the care of an emergency profession unless the person being transported requests transport by law enforcement. Does that help you?
it doesn't, because I go back to what I had said originally. These are folks that are being taken against their will, involuntary. And then you're offering them a choice of the transport to the facility that they don't want to go to. And they're in a mental health crisis. So I don't believe that many of them would have the rational ability to make that choice.
And could I have one more follow-up?
Sure.
Thank you. In your experience here, Ms. Stevens sort of made a difference between 2 stages of involuntary, one of which is the people who don't want to go, but who will say, okay, I'll get in the ambulance, or okay, I will get in the police car. And the people who absolutely will not do either of those things unless they are compelled to by whoever's doing the compelling. Are you also of the opinion that the most involuntary of the involuntaries are relatively rare, and that more of the people who don't want to go do wind up saying, yes, I'll do it this way or that way?
I hesitate to answer because to reach the involuntary stage is quite a process to get to.
Okay.
So I would have to suspect, and I'm admittedly not qualified to say, that to get to that point, you have crossed a number of different thresholds from a mental health crisis component.
Okay, thank you.
Anyone else? Representative Woods.
Thank you, Mr. Chair, and thanks for taking my question. At the risk, I'm going to ask a variation of my previous question because I didn't really ask my question correctly. In paragraph Roman 4, it seems to me that there's a potential that the person in the ambulance, because it says shall be transported by an ambulance, may not feel comfortable transporting that ambulance. But it can only be overridden if the police officer says that they don't take it. Is there ever a situation where there's a conflict between those two? The ambulance person says, no, I really don't want to take this person, and the police officer saying, oh, you'll be fine, you'll be fine. Is there ever any conflict there?
I'm sure that potential exists. And then, if you look at the landscape of New Hampshire, there are communities north of Concord that a police officer is just as scarce as an ambulance. And what are the resources that are available to make sure that, not only is the patient safe, but the ambulance provider that's in the back of a moving vehicle is safe with that patient as well. I've unfortunately in my career seen patients elope on the Everett Turnpike that were being transported with one person in the back. And those are things that you have to do everything in your power to make sure that they don't happen.
Anyone else? Okay, I'm seeing no one else. Thank you.
Thank you.
No one else has signed up to testify on HB 1070 FN. Does anyone else wish to testify? Seeing no one, I'm going to close this public hearing on this bill. That concludes our work for the morning. We are scheduled to be back here at 1 to hear testimony on HB 1249. We will be in recess until then. Good afternoon, everyone, and welcome back. The next bill to be heard this afternoon is HB 1249. I will recognize the prime sponsor, Representative Vayu. Am I pronouncing that name correctly?
Yeah, perfectly. I appreciate that. Good morning, Mr. Chairman and members of the committee. For the record, my name is Dan Vayu. I represent Hillsborough 34, the town of Amherst. I'm here to introduce HB 1249, authorizing pharmacists to provide certain medical devices associated with prescription medication. My son has asthma. When he was a baby, he experienced a severe episode of reactive airway disease that brought us to the doctor's office, where he was prescribed he was given a nebulizer, and we were sent home with medication, and he was fine. That was not the scariest incident. We had one far worse, where we spent a couple days in the hospital. If you're unfamiliar with what a nebulizer is, it's a device that turns a liquid medication like albuterol into a vapor, so it can be inhaled through a breathing tube or a mask. If you ever watch a child struggle to breathe, you know it's one of the scariest things a parent can experience. Having a nebulizer on hand is critical to addressing asthma symptoms early and effectively, which can mean the difference between managing it at home, as we've been able to do several times, or ending up in the emergency room. I still get kind of choked up about that experience, and very thankful that we had the equipment and the medication on hand. Fast forward to a few months ago, everything's fine. Everything's going well. My son misplaced the spacer for his inhaler. Simple problem, we didn't think anything of it. Inhaler is just a simple tube that allows the medication to aerosolize, so it goes into the lungs rather than the back of the throat and ending up in the stomach. So we went to the pharmacy where he gets his inhaler's prescription filled, and they said, no, we can't give you one because it's considered a medical device, and we need a separate prescription for it. You know, extend that to like another device like a nebulizer, and this could be a critical situation where you end up in the emergency room rather than just going home. Ironically, I was able to order the tube online and had it the next day. That experience made me look more closely at the issue when I found that it's more than just nebulizers and inhaler spacers and simple things like that. It also extends to insulin pen needles for people who have diabetes, syringes, CPAP supplies, diabetes testing supplies, things that are often critical to treating life-threatening diseases at home. HB 1249 addresses this by allowing pharmacists to dispense these devices if there's already a prescription for the medication that can only be administered through the use of these devices. I worked with the Honorable Gary Merchant, former member of this committee, on the language which we borrowed largely from the state of Indiana, but there are close to a half dozen other states that have similar laws in place for similar reasons. It's simple reason behind the bill, and I'll be glad to answer any questions.
Okay, thank you. Representative Weber.
Thank you, and I appreciate the intent of the bill very much. My question is, I'm looking and I haven't seen it yet, so am I missing the place where it requires, maybe it's an existing law, where it requires the pharmacist to have received a prescription for the underlying medication or treatment? Because I'm thinking about, I'm thinking specifically about a CPAP machine, and that also is by prescription, but it's far less sort of related to something else that is being prescribed. So where does it say that these have to be under a prescription prescribed by a different licensed professional?
For CPAPs, I'm not sure. These are all FDA regulated. I think it's under federal law where these are required prescriptions. So unless a state has provided other authority to pharmacists, they would have to be prescribed only by a physician, or they could only be provided through a prescription through a physician. This would allow, and if there's an underlying medication that is already prescribed, but the device is not, this would allow the device to be provided as well.
And if I may,
Follow up.
would you be interested to know that with a little help from my friends, I've now determined that it actually is under on line 21 and 22. That's on the order of a licensed practitioner. So thank you.
Sure.
Representative Palmer.
Would you believe that I've spent hours looking for the little thing for pen needles in our EMR and would be grateful not to have to do that?
I would believe it.
Representative McGrath, and then Representative Palazzo.
So as a pharmacist, I think this is excellent. You said in Indiana, do you know if insurance companies would cover it using our NABP or MPI number? Or if they would have to pay cash for it?
That's a good question. I don't know that. I know that insurance companies are wary of this in some ways, but for me, it's, if I need the device, I mean, I was willing to pay cash for it at the pharmacy just to have it. And in a lot of cases, having the device is going to be less than the copay at an emergency room. So just having it available is the important part. We can discuss the insurance part afterwards, I guess. So it would be an important thing to clarify.
Follow up.
Would you believe that patients get angry at us all the time because the insurance doesn't pay?
I would believe it, yeah.
Other questions? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So in your research for this bill, what are the intentions behind current situations? Are these devices dangerous, or are they could be used for illicit drugs, or like why current limitation exists?
Yeah, that's the concern that I had, and that's why there has to be a prescription on file for the medication that would require these devices. Specifically, I think what you're referring to would be the needles. If you would have to show that you're there to pick up your prescription that requires your syringes, and the syringes aren't on the prescription, that would be the only way they would be prescribed. And in most cases, I think it's more of a supply side care about for pharmacies to make sure that they're administering to people that really need the devices, so they're not sold out just because somebody wanted to go in and buy up their stock for whatever reason.
Anyone else? Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. So I personally have experience with this because I had to have a nebulizer. I do have reactive airway disease also. So I did go through that process. And in that process, I noticed that they gave us a paper that said all of the approved devices that they would have to go through. I saw in that paper. Do you think the state would you think we should be focused on that too and add that information that I know the federal standard has with those devices to make sure they're noted in here somehow so that we don't have an insurance issue or something along those lines because it deems those specific devices?
Yeah, if you feel that it's unclear or needs to be noted in here, I would support an amendment if that's necessary. Absolutely. And with the nebulizer, because it was given to us in the office, there was never a prescription for it. So, if it breaks or you get it home and it's not working and it's after hours and it's Sunday afternoon and there's nobody around, what do you do? You'd have to go to the emergency room. That would be your only option to treat the problem.
Anyone else? Yeah, I see no one else. Thank you.
All right, thank you.
No one else has signed up to testify on HB 1249. Does anyone else wish to testify? Okay, seeing no one, I'm going to close the public hearing on HB 1249. Scheduling bills is not an exact science. We allowed an hour for this hearing, and so we will be in recess until 2 p.m., at which time we'll hear HB 1335.
Wow.
We're in recess.
Better than going home. Right, no kidding.
There wasn't notice.
suddenly able to do things for themselves, and they're excited about it.
Okay, welcome back for the final hearing of the day, HB 1335, and I'll recognize Representative Wary for the purposes of introducing the bill.
Thank you, Mr. Chair and honorable committee members. For the record, my name is Robert Ware. I have the privilege of representing Hillsborough District 13, great town of Hudson. I am testifying in support of this bill to require health care providers to disclose to patients when they are receiving a substantive financial incentive that might otherwise bias them. I won't read my testimony, but let me try and cover a few highlights here for you. Is that I have in my career audited a number of entities involved with clinical research trials, and including investigator sites and IRBs, investigational research boards, CROs, contract research organizations, sponsors, and manufacturers. And one of the most important aspects of about that is in clinical research is financial disclosure by clinical investigators. I'm going to read a part from Part 54 of the Code of Federal Register, CFR, and it's in the box there. FDA may consider clinical studies inadequate and the data inadequate if, among other things, appropriate steps have not been taken in the design, conduct, reporting, and analysis of the study to minimize bias. One potential source of bias in clinical studies is a financial interest of the clinical investigator in the outcome of the study because of the way payment is arranged. A royalty, because the investigator has a proprietary interest in the product, a patent, or because there's equity and interest in the sponsor of the covered study. So that's the main principle, is that if there's a financial interest involved, it may bias the clinician. So that any potential bias can be recognized, clinical investigators must disclose their relevant financial interest and potential conflicts. And the idea here is the same practice should apply to the healthcare marketplace. If someone is receiving a undue amount of money, bonus money for prescribing according to a specific insurance or institutional formulary or schedule, and they're getting reimbursed not for the service, but because they've accumulated enough patients to prescribe from that formulary, then it's possible that they are being biased by that practice. So this bill provides mechanisms for the disclosure of these incentives to patients. If a doctor is not receiving any of these incentives, then they don't have anything to disclose, and they're immune from the consequences of this proposed bill. If a doctor is only receiving mild compensation for a speaking engagement or a medical conference, very common practice, then there's a $5,000 threshold. I'm not beholden to $5,000. That can be increased if you think that's too low of an amount. And any aggregate monies received below a threshold that's established would not have to be reported. So those doctors without potential bias due to the financial incentives have nothing to report. Those with a modicum of compensation under the threshold have nothing to report. A few doctors receiving more extensive bonuses and incentives would be the only one to whom this law would apply. Patients have a right to medical transparency through proper informed consent practices. This bill enables medical transparency through the disclosure of incentives and includes financial incentives within the informed consent process. If the FDA requires disclosure for clinical research, and I have copies of the regulations if anyone wants to see those, New Hampshire ought to have the same protections on the commercial side of medicine. So I urge you to support this bill. That finishes my testimony. With the indulgence of the chair and the committee, I have a very, very brief testimony from another representative who could not make it here today. This is from Representative Belcher. He said his testimony is, quote, "My search for a pediatrician for my daughter who would accept us as patients if we planned to refuse even one of the many recommended vaccines was extremely fraught and took very much effort. In this process, I learned that some insurance might significantly financially incentivize doctors to achieve perfect vaccination rates among their patients. This is a direct conflict of the patient-doctor relationship with doctors, now incentivized financially to coerce decisions that are the right of parents to make. This is the least we can do to provide transparency, meaning this bill. So thank you for also listening to that. I'd be happy to take any questions that you may have.
Okay, thank you. Any questions? Representative Woods.
Thank you, Mr. Chair, and thanks for taking my question.
Yes.
This has the flavor of those doing research, but had you intended this for just the practicing physician in the office?
Yes, just for the practicing physician. That's correct.
Okay, I'll follow.
Oh.
Were you aware that by statute, physicians in New Hampshire are obligated to the, I'll read this, a licensee shall adhere to the Code of Medical Ethics, current opinions with annotations, and that's the standard to which physicians are held in consideration with the Board of Medicine and in the legal community. Did you know or compare those two by chance?
I did not do that comparison.
And that's the standard in statute now.
So if the implication is then that they should not be accepting any of these financial incentives.
That's correct.
I believe that's not being followed then.
Yeah. No, I just didn't know if you were aware.
Thank you.
Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I'm just curious why you limited this to physicians, because virtually every healthcare provider, from physical therapists to pharmacists to optometrists to occupational therapists to on and on, this is an issue for all of them, I would think. And I'm just curious if you ever thought about it being much more expansive than this.
Thank you for your question. I think that's a great question. I think I was thinking primarily that in specific practices it would be the head physician receiving that incentive, but you're absolutely right. It could be more expansive.
It's slightly related, but you pointed out very aptly in your testimony that most physicians are employed by somebody right now, and
yes.
The incentives may not be directly to the physician, but to the entity that they're employed by, dictating to the people that provide the service. And I'm just curious if you ever thought about that as well, including that in this. And I do like what you've done here. This is important.
Well, thank you for that, and thank you for your question. Yeah, I do allude to that in since I think about the 80s, it's because of HMOs, the flip between independent doctors and institutional closely associated to institutions has radically changed in the last several decades. And I think personally, again, this is sort of my personal opinion, I think it affects how doctors take care of their practice. And so I think certainly a follow-up bill to address institutions or something like that may be very well appropriate. That's a good direction to head. Thank you.
Representative Tejas.
Thank you, Mr. Chairman. Thank you for taking my question. So I don't practice currently, but I practiced for a while, and I know a lot of docs. I'm having a hard time really imagining what scenarios you're specifically referring to of how, like what in practice is happening so that people are receiving. I've never heard of this, basically. So maybe there's certain kinds of circumstances where it is happening, like if someone is a self-employed direct provider, like I just can't envision this, especially as you pointed out, most physicians in New Hampshire are employed.
Thank you for your question. I think you raised an interesting question because I do think it gets to what Representative Woods brought up earlier. Is it's an ethical question to some degree, And so I think there are a lot of good doctors who would not allow themselves to be biased in this way. But I think nonetheless, as I read through Representative Belcher testimony, there are some who are unduly influenced this way and perhaps in an unethical manner. And we have reported cases of it, and there have been in other states, there have been formularies that specifically prescribed a level of, or specifically dictated a level of patient adherence to achieve in a practice, and if you met that criteria, it would be awarded as a bonus. You're welcome.
Anyone else? Representative McLean.
Thank you, Mr. Chair, and thanks for taking my question. So I don't have RSA 329 in front of me, but I'm assuming that in there is like there's no penalty section explicit in the bill. So is there something in RSA 329 where there's a consequence for not complying with this?
I don't believe so. I do believe that RSAs have a general penalty for noncompliance that would apply in such circumstances. Forgive me, but I don't recall it right off the top of my head. I did not see any explicit. When I was looking at the regulation in order to craft this with OLS, I did not see any. I don't recall seeing anything specific to the financial penalty or a penalty or anything like that.
Right, thanks.
You're welcome.
Representative Drew.
Thank you, Mr. Chair. Would you believe that the default penalty for violating an RSA is a violation and up to a $1,000 fine?
I would believe that, actually. Thank you. I knew I had heard it somewhere. Thank you for providing that information, Representative Drew.
Anyone else? Representative Palmer.
Thank you, Mr. Chair. Thank you for taking my question. One part, the first half is not really a question. It's just I remember that one of the people that I worked with early on in my career, who was in private practice at the time, started selling this diet formula and was bragging about how much money he was making off of it. And it turned out that diet formula also tended to cause major gallstones, and multiple people ended up needing surgery. So there are other reasons why this might be a good good plan. My question, though, is it's just in how this would work. I guess if that doctor was prescribing this or selling this formula to a patient, you envision that he would have to have a form that said, I am making $500 selling you this, something like that.
Yes, it would be. Yeah, it'd be like any kind of informed consent disclosure form, I would think. And thank you for your testimony too. That's a classic example of that sort of situation. But yeah, I think just a form that notifies the patient that, or the guardian or parent, I guess, that this is occurring. So yeah.
Representative Plazoff.
Thank you, Mr. Chair, and thank you for taking my question. So I wonder about line 7, third party. In your testimony, you gave as an example of insurance companies promoting certain medications by providing certain incentives to certain medical practices. I don't know how deep you were involved in crafting this language, but in your view, this third party, like how wide is this category? Like if I don't know, if federal government, if CDC is having some guidances and offices receive some federal funding, for example, how wide reporting and previous question was about diet. So sometimes if we have recommendations that like your doctor should recommend kids a lot of fruits, even vegetables, like how much do we need? Would we doctors need to disclose that they're incentivized to recommend vegetables?
Well, thank you for your question. I think if they're receiving a direct reimbursement or some, I think what it was meant to accomplish is when there's a direct incentivized payment to the prescribing entity, whether it's a physician or to Representative Nagel's point, a more expansive group of people. I think it's are they receiving a direct incentive? Hey, you sell X number of product Y, then and you get your patient demographics up to 90% compliance, then we will incentivize you with a $5,001 bonus. They would have to report that.
Anyone else? Representative Tejas.
Thank you, Mr. Chairman. Thank you for taking my question. So I'm still really struggling. I see that in your testimony, I circled like the incentive and bonus money, which to me sounds more like a thing related to, you prescribe X or over Y, not because it's medically necessary, but because you're trying to meet some whatever imposed by whoever. So there's that dimension, and as was just mentioned earlier, there could be other ways that is trickling down where the provider doesn't even realize it's an incentive. It's more like a guidance from the institution. So I think that's what's coming to mind. But then when I look at the language of the bill, it talks about a lot of other things, and the example that Representative Palmer shared is if I sell, whatever product in my office, that to me doesn't read as even being on here, which is selling stuff, right, which is different from like a bonus or an incentive or a promotion. So can that be added in? Because
yes. Thank you for your question. I think fundamentally the bill is trying to address patient safety through proper informed consent and to eliminate bias from any prescribing entity who's receiving a financial compensation. So I think, if you want to expand the categories that are involved there, I'm certainly open to that. If Representative Nagel wants to expand the entities that are involved in that, if Dr. Palmer, Representative Palmer wants to expand the entities relating to diet products, I'm very happy for that. The fundamental thing is to protect people so they're not getting things forced on them that might otherwise be bad for them.
Yeah, I'm just, I am still struggling with the fundamental concept. I don't know that, I heard the one example that you shared, but I'm not really, I'm having a hard time with, as a researcher by training, like, accepting that this is something that's happening a lot. And then I wonder if sort of separating out, like, I'm thinking about how, like, when you go present at a conference, you have to do a disclosure. You have to disclose if you're getting any kind of, if there's a conflict of interest, if you're getting, like, the CME process is very rigorous. It's very much, a lot of people review things before you're allowed to present. They make sure that there's no financial conflict of interest. So those processes are in place. So I wonder if maybe teasing out some of the stuff that's already covered, like the conference type thing, could be helpful.
The $5,000 threshold was, thank you for your question. The $5,000 threshold was, and a single entity, $5,000, so there could be multiple conferences, different people. So in in that situation, it was meant to there's not one single entity saying, we will, if you prescribe our product a lot, we will give you speaking engagements at 4 different conferences and pay you $10,000 for each conference. That is a nice, sneaky way to pay someone for prescribing medicine. And so in that sort of situation, that's what this bill would try to avoid. I think if they're doing actual clinical research, I agree with your point. They're already disclosing those aspects. So it's not someone who's doing clinical research. It's and is conducting a clinical study to evaluate an investigational product. It's simply someone who is, and maybe if the language needs to more specifically exclude that, I would be fine with that. But I think the main point is someone who is not involved where they already have to disclose those types of financial incentives.
Anyone else? Anyone else? Representative Nagel, did you have your hand up?
I'm sorry, this is a would you believe question.
I would.
Would you believe that there are regenerative medicine centers in this country where the people providing the service are paid a substantial kickback to provide the service and basically take advantage of poor people? And I'm assuming that is why you want to do something like this?
Thank you for your question. And your would you believe. I have in my career seen those sorts of things happen. The poor people are often taken advantage of. Neil Young's song, "The Needle and the Damage Done," milk blood to keep from running out. He talks about selling his own blood so that his friend Danny Whitmore, I think, who sold his blood so that he could get more money to buy drugs. I mean, poor people and disadvantaged people are always taken advantage of. So if we can protect them in some way, that's a good thing.
Okay, I'm not seeing anyone else.
Thank you very much.
Thank you very much. No one else has signed up to testify on HB 1335. Does anyone else wish to? Seeing no one, I am going to close the public hearing on HB 1335. That concludes our public hearings for today. We will be going into executive session at 2:30 and considering several bills that have been noticed. Until then, we'll be in recess. To order on several bills that were noticed for today at 2:30. The first one, and I thought I had all my paperwork in perfect order, and of course I don't.
I haven't touched it.
No, I'm not gonna blame you. Yeah, no, I know. First bill up is HB 1022, and I believe Representative Drew, you have an amendment and a motion.
I do have an amendment, but I appear to have misplaced my copy.
I know how you feel. I just kind of misplaced something too. So.
Oh, thank you. Is it? No, yeah. I would move OTP on amendment 2026-0814H.
Okay,
For HB
and
1022.
Representative DeLamus, I believe you
Second?
have a second for that. Do you wish to speak to your motion?
Yes, thank you, Mr. Chair. This amendment is extremely simple. All it does is, per suggestions from the committee, it adds a spot for putting in the child's name and the child's date of birth into the text that's for the statement.
Okay, Representative DeLamus, do you have anything to add? Or?
No.
Any other discussion? Okay, I'm seeing no discussion. So the motion is ought to pass on amendment number 2026-0814H to House Bill 1022. Madam Clerk, if you're ready, please call the roll.
Representative Mazer,
Yes.
Representative McLean,
Yes.
Representative DeLamus, yes. Representative Copal,
Yes.
Representative Palumbo,
Yes.
Representative Drew,
Yes.
Representative Nodder,
Yes.
Representative McGrath,
Yes.
Representative Kesselring,
Yes.
Representative Weber,
Yes.
Representative Nagel, Representative Woods, Representative Palmer,
Yes.
Representative Mateus,
Yes.
Representative Lamontagne,
Yes.
Representative Bay,
Yes.
Representative Lucas,
Yes.
and Representative McDonald.
Yes.
Well, that's 18. 18 yeas, 0 nays.
Amendment passes 18-0. Representative Drew, do you have another motion?
Thank you, Mr. Chair. I do. I move OTPA on HB 1022.
I second that.
Representative DeLamus seconds. Any other discussion?
Pretty much just what I said before. This is an alternative to an issue that's, frankly, it's surprising that it is an issue, but it came up this way. So what happened was, historically, there was a change to this particular statute that specified a form, and then DHHS created a form. There was some contention over the form. We attempted to pass a bill that said it just needed to be a statement. I believe the governor vetoed that. And so this is one possible alternative, and it simply specifies the language for the vaccine exemption, the religious exemption, to simply state that the parent or legal guardian is choosing a religious exemption for their student, and that's it.
Okay, thank you. Representative Weber.
And I would just note, as we have before a number of times now, that the form that is available for use is a simple standardized form. It does not provide any additional intrusive information other than identifying the student and helping whoever's organizing the records at the school to keep things in an orderly fashion, and therefore I don't think any change is made. It simply allows one to, as this does, assert the exemption, only it does it in a way that is just easier to process. So I'm going to vote against it, but thank you.
Thank you. Representative Woods.
Thank you, Mr. Chair. Just to continue that thought, just from the safety perspective, having good data, which the form would provide, over and above just sending in any kind of notification, notifies everyone. Those who have declared they don't want a vaccination would then still be noticed that, in fact, there might be a measles outbreak, and then make good decisions about their child. But not having that data would preclude everybody from being able to make that decision in a good data-based, data-founded decision. So I would vote against this because it detracts from both vaccinated and unvaccinated healthcare.
Okay, thank you. Anyone else? Seeing no one else, ask the clerk to call the roll. Motion is ought to pass as amended on HB 1022.
Representative Mazer,
Yes.
Representative McLean,
Yes.
Representative Delamus, yes. Representative Copal,
Yes.
Representative Pelosi,
Yes.
Representative Drew,
Yes.
Representative Nodder,
Yes.
Representative McGrath,
Yes.
Representative Kesselring,
Yes.
Representative Weber, no. Representative Nagel, Representative Woods,
No.
Representative Palmer,
No.
Representative Fayez,
No.
Representative Lamonte,
No.
Representative Bay,
No.
Representative Lucas,
No.
and Representative McDonald.
Yes.
That is 10-8. And the motion passes.
And Representative Drew, you'll be doing the majority report, I assume?
Yes.
Thank you. And Representative Weber, do we know who?
I believe that's going to be Representative Lucas,
Okay,
with the last one.
okay, thank you.
And the motion would be ITL, Lucy?
Yes, our motion would be ITL.
Okay.
Okay, great, thank you. Next up is HB 1219 and Representative McGrath. I believe you have a motion?
Yes, ought to pass on 1219.
Second.
And Representative McLean seconds. Do you wish to speak to your motion?
Yes, so this is very simply make sure that everybody in a foster family is not subject to more immunization requirements than other families. And with the shortage of foster families, some have dropped out because of the increased requirements. So that's all this does.
Thank you. Any other discussion? Representative Woods.
Thank you. Thank you, Mr. Chair. Again, this is the same argument we've had before, that the non-vaccination, and it's even a greater pool in this situation. It involves the parents. And for all the reasons that we've been over before, it's just very poor medical practice. And we're charged with the general welfare of the population. And to take this position would be an abrogation of that duty.
Okay, thank you. Representative Lamontagne and then Representative McLean.
Yes, I'm not going to support this motion. I think the argument that we don't have enough foster parents because we require, I think it was just one more additional vaccination for foster parents of an infant under a year old to get the flu shot. The woman who at DHHS who recruits foster parents says she's never heard of any foster parent declining participation because of the vaccine requirements. So I don't think it's necessary. Potentially harmful.
Representative McLean.
Thank you, Mr. Chair. I mean, I think that the people who step up to be foster parents are very special. It's a very high bar, and I'm fortunate enough to know some of these people, and one of them who did back out because of the vaccine, not for themselves, but because it was a requirement for their child. So I don't think and they had everything that was required of every other person they had done, but the fact that more vaccines were being required, they were okay for themselves, but they were not okay for their children. And so they did step out of the program. And so I think that this is a good common sense bill. The bar is high enough already, and I think this bill makes sense.
Representative Weber.
I won't reiterate what's already been said, but I want to just note that what we were told, I believe, was that the requirements for the foster parents come from federal law. And as the bill notes, we're comparing to state regulations for other families. And I just remind people that the federal law in this area is in a great deal of flux right now. So before we take a step that might be completely unnecessary, perhaps we ought to watch what's coming down from the federal government, because that's what's driving this particular train.
Okay, thank you. Anyone else? Representative Woods.
Thank you, Mr. Chair. Just to clarify, I did try and do some research on the issue that was raised about the federal regulations, and there is some flux. I think, and I thought I brought it with me, but apparently I did not. The federal rules, the way it states right now, refers to state law as the criteria. So, but I still have that under research, but that's the best I could determine at this juncture.
Okay, thank you. Anyone else? All right, saying no one else, I'll ask the clerk to call the roll. A motion is ought to pass on HB 1219.
Representative Mazer?
Yes.
Representative McLean?
Yes.
Representative Delanis? Yes. Representative Copal?
Yes.
Representative Colasar?
Yes.
Representative Drew?
Yes.
Representative Nodder?
Yes.
Representative McGrath?
Yes.
Representative Kesselring?
Yes.
Representative Weber?
No.
Representative Nagel? Representative Woods?
No.
Representative Palmer?
No.
Representative Tejas?
No.
Representative Lamontagne?
No.
Representative Bay?
No.
Representative Lucas?
No.
And Representative McDonald?
Yes.
10 to 8. The motion passes.
Representative McGrath, you're going to do the majority report, and minority report will
ITL, Representative Woods.
GL and Representative Woods.
That's right, isn't it? I don't want to be springing something on you.
We like volunteers. Okay, next up is HB 1316. Representative Mazer, I believe you have a motion.
Yes, thank you, Mr. Chair. I'd like to motion ITL on HB 1316.
And Representative Kesselring?
I second.
Okay. Representative Kesselring seconds the motion. Representative Mazer, do you wish to speak to your motion?
Yes, very brief. It's already covered in federal law, covered in HIPAA, Americans with Disabilities Act, and others. And those already strictly regulate disability and health data. And there's also a risk of funding for Medicaid that might be affected, and why single out one group versus the others. So that's why I'm voting ITL on this.
Okay. Any other discussion? All right, seeing none, I'll ask the clerk to call the roll. The motion is inexpedient. I'm sorry, Representative Lamontagne, I'm sorry.
I actually would like the committee to consider a work session to look at both HB 1316 and 1317, which both, they're looking at similar concerns in different part of statute. And I'm wondering if we couldn't take what's really worthwhile in some of them regarding healthcare protections, particularly with a lot of new, what was the term? Data scanning or that we don't really have protections for that in statute. And neither of them are, early bills that we need to send to another committee. And
you do have like 2 weeks left.
I already motioned ITL though.
Right, I mean,
so,
we are.
Well, I'm just saying why I'm not in favor of ITL.
Sure.
I would
No,
like to
that's fine.
consider another motion.
We are late in the game for work sessions and additional meetings, stuff like that. But no, I appreciate your sound. Did I see another hand up? Or? Okay. Motion is inexpedient to legislate on HB 1316.
Representative Mazer?
Yes.
Representative McLean?
Yes.
Representative Delanis? Yes. Representative Copal?
Yes.
Representative Colasar?
Yes.
Representative Drew?
Yes.
Representative Nodder?
Yes.
Representative McGrath?
Yes.
Representative Kesselring?
Yes.
Representative Weber? No. Representative Nagel? Representative Woods? No. Representative Palmer?
No.
Representative Tejas?
No.
Representative Lamontagne?
No.
Representative Bay?
No.
Representative Lucas?
No.
And Representative McDonald?
Yes.
That is 10 to 8, and the motion passes.
Okay. And Representative Mazer, I think you've already done a report, right?
Yep.
And Representative Weber, any idea on the minority?
I think our recommendation would be out to pass, and I believe that Representative Lamontagne is going to be doing.
Okay. All right, very good. Next up is 1317, and Representative Mazur again.
Yes, thank you, Mr. Chair. I'd like to motion ITL on HB 1317.
And I will second the motion. Representative Mazur, do you wish to speak to your motion?
It's really the same reason as HB 1316. And we actually heard a lot about like fear of this bill was driven by fear of the current administration. And that, to me, is not a reason to put a bill in because you're fearful of the present administration. And we heard that several times throughout all of it. And then we heard, and then no other issues of why this was an issue. So that was confusing. And then again, it's covered in all of the acts that I mentioned previously. So all of this already exists. So to me, this is just kind of a duplicate of what's already out there.
Okay. Representative Weber.
Thank you, Mr. Chairman. I would just say that in a state where we just passed a constitutional amendment respecting patient privacy, respecting privacy of all aspects of people's lives from intrusion by the government, I think that having a little added protection for the privacy interests, particularly with respect to healthcare, which is one of the more intimate aspects of our lives, is not a bad thing. And I think my understanding was that this was to give full voice to the protections that we have in the Constitution and that need to be more broadly expressed in the general population.
Thank you. Any other discussion? Well, no, it's I'm never sure when you're raising your hand. Or,
Right.
Neither am I. No, I really appreciate what Representative Mazur said because, you know, when I first looked at these two bills, my impression was this is already covered, and I wasn't sure something was necessary. We talked about other issues. And my personal feeling, I would have done an interim study. That would have been what I would have thought, and that's why I've been struggling with how to vote with these. But I really appreciate being informed about the federal statute oversight of this.
Thank you. Seeing no one else, I'll ask the clerk to call the roll. The motion is an expedient to legislate on HB 1317.
Representative Mazur,
Yes.
Representative McLean,
Yes.
Representative Delamus, yes. Representative Copal.
Yes.
Representative Palazzo,
Yes.
Representative Drew,
Yes.
Representative Nodder,
Yes.
Representative McGrath,
Yes.
Representative Kesselring,
Yes.
Representative Weber,
No.
Representative Nagel.
No.
Representative Woods,
No.
Representative Palmer,
No.
Representative Payas,
No.
Representative Lamontagne,
No.
Representative Bay,
No.
Representative Lucas,
No.
and Representative McDonald.
Yes.
Okay, well, that is 11-7. And the motion passes.
Okay, and Representative Mazur, you've already done the report, I believe. And minority report?
I will do a not to pass minority report.
Okay, next up is HB 1318. And I sensed from different discussions I've had that that's more broad support. Actually, I'll move to pass on that. 1318. Representative McLean seconds. And you know, when Representative Nagel testified, he we appreciate the report, Representative Nagel, you submitted to us. Your committee has done good work, and we think it's worth continuing. And it's a committee we know that does meet, does function, and again, we feel that it should continue. So, for that reason, I'm moving on to pass. Any other discussion? Oh, Representative Nagel. Okay.
I'm really honored you said that I know what we say about committees and that, but this has been a really motivated committee. We try to keep it small on purpose just to keep the motivation, but I was just really honored when we had our committee vote about do we want to continue this or not, and everybody said, yeah, we really need to do this. That's exciting. And also, I also wanted to add one thing is when I did my testimony before, I had mentioned that we were looking for an urban site to match our rural site, and we found that yesterday. So it's been an exciting 24 hours for me. So I appreciate that. Thank you. It's going to be in Portsmouth area. Yeah. And it was a total accident. It's really weird how it happened. So sometimes the best things in life happen on Mardi Gras for all of them. Since we brought that issue up earlier.
Oh boy.
Representative Palazzo.
Thank you, Mr. Chair. I will be voting no because although this committee has a very noble goal, it sounds like it's pretty much done its purpose. Pilot programs are here, and 2 meetings that are needed could be done over video conferencing or some other way. So I'm not convinced that it's needed.
Okay, thank you. Anyone else? Seeing no one else, I'll ask the clerk to call the roll. The motion is ought to pass on HB 1318.
Representative Mazer.
Yes.
Representative McLean.
Yes.
Representative Delamus, yes. Representative Copal.
Yes.
Representative Palazzo.
No.
Representative Drew.
Yes.
Representative Nodder.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
Yes.
Representative Nagel. Representative Wood.
Yes.
Representative Palmer.
Yes.
Representative Tejas.
Yes.
Representative Lamonte.
Yes.
Representative Bay.
Yes.
Representative Lucas.
Yes.
And Representative McDonald.
Yes.
Okay, well that is 17 to 1. 17 to 0.
Okay, and
Motion passes.
I'll do the majority report, and Representative Velazov, it didn't sound like you were thinking of a minority report or do you oppose consent? Are you agreeable with consent? Or? Okay, great, thank you. Great, thank you. Okay, next up is HB 1321, and Representative Kesselring, I believe you have a motion.
Yes, thank you, Mr. Chair. I move in expedient to legislate.
And Representative Drew?
I second.
Okay. Representative Kesselring, do you wish to speak to your motion?
Yes, I would. So, as far as we heard on the testimony, this is definitely something that we should look at in a different way. While I appreciate the intent of it, the committee, or at least I hope, will find that we have a lot of things here in this bill that have an issue. There's a lot of unintended consequences that could come from this, the way it's written. So that's why I'm putting forward in ITL.
Okay, thank you. Any other discussion? Representative Nagel.
I really appreciate what you just said because there's a lot missing from here, and I would have either gone interim study or ITL. For example, like what about paramedics? They probably put in more IVs than anybody. There's a lot of missing pieces to this thing, and by itself, it's not a good bill. But could it be better? Maybe. But I could be persuaded either interim study or ITL.
Thank you. Representative Drew and then Representative Woods.
I just wanted to say that I think the approach of this bill is wrong. And I say that as, again, I keep reminding people of this. I've been the subject of a medical professional attempting to insert an IV. It was very unpleasant. The Venn diagram overlap between medical professionals as a general group and people who know how to properly administer an IV. There's not a lot of overlap in that group, sadly. So I think this is restricting it to medical professionals is entirely the wrong approach.
Representative Woods. Okay. Anyone else? Seeing no one else. Okay, the motion is inexpedient to legislate on HB 1321. Madam Clerk.
Representative Mazer.
Yes.
Representative McLean.
Yes.
Representative Delamus, yes. Representative Copal.
Yes.
Representative Palazzo.
Yes.
Representative Drew.
Yes.
Representative Nodder.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
Yes.
Representative Nagel.
Yes.
Representative Woods.
Yes.
Representative Palmer.
Yes.
Representative Tejas.
Yes.
Representative Lamontagne,
Yes.
Representative Bay,
Yes.
Representative Lucas,
Yes.
and Representative McDonald.
Yes.
That is 18-0, motion passes.
Wow. Okay.
Very nice.
Representative Kesselring, you'll do the majority report? And obviously, there will be no minority report. Any objection to consent? Okay, great, thank you. Okay, next up is HB 1368, Representative Palazzo.
I move for an expedient to legislate.
Okay, and Representative Drew.
Second.
Do you wish to speak to your motion, Representative Palazzo?
Just briefly, I don't think we need another committee overseeing existing committee, and we see that there's a major push going on already to help medicine in rural areas, including funding for rural access. So I don't think this is needed.
Thank you, Representative Palmer.
So I agree that this bill starting another committee is not a great idea, but I do appreciate Representative Opal's re-emphasizing the need for primary care. I think unfortunately a lot of that, we know a lot of the problems already, and there are groups working on it, and part of the biggest part of the problem has to do with the federal government. So I basically agree with this motion.
Okay, Representative Nagel.
Thank you, Mr. Chair. I appreciate everything you both said, and I totally agree. The one thing I feel obligated to point out is that I love our focus on rural health, but we have two deserts in our society. We have inner city and rural. They're both problems, and I do appreciate this, but I just hope we don't forget that we have an inner city issue as well, which I think we have forgotten.
Representative Weber.
And just as a follow-on to all of that, I will point out that since this bill was drafted way back in September, we have also had the advent of the Rural Health Transformation Grants, which are going to look at this issue, and because all of New Hampshire qualifies as rural, we can study our own rural deserts and our own inner city deserts, both of which we have. And so I too am going to vote for the ITL motion. Thank you.
Thank you. Representative Nagel.
I just wanted to also add to all four previous comments that we actually, the focus of our rural transformation money right now for this first year is primary care and rural environments and preventative care. And we got a lot of slaps on the back, pats on the back for doing that at the federal level. So that's pretty exciting. And I will also add, I've really quizzed about this, but we do definitely can't use this funds for certain elements of our urban care, which really bothered me a lot. But we tried to figure out if we can do that, but it doesn't look like we can. So,
thank you, Representative Hayes.
I was just going to add that in addition to what can be done at the Shaw Ship and with the Rural Transformation Grant, there's the Legislative Commission on the Interdisciplinary Primary Care Workforce, and I think members will be amenable to studying a lot of the stuff that hasn't yet been studied and putting it together in a helpful way, in collaboration with whatever Shaw Ship and the other entities do.
Thank you. Anyone else? Okay. Seeing none, I'll ask the clerk to call the roll. The motion is inexpedient to legislate on HB 1368.
Representative Mazur.
Yes.
Representative McLean.
Yes.
Representative Lamus, yes. Representative Copal.
Yes.
Representative Palazzo.
Yes.
Representative Drew.
Yes.
Representative Nodder.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
Yes.
Representative Nagel. Representative Woods.
Yes.
Representative Palmer.
Yes.
Representative Tejas.
Yes.
Representative Lamontagne.
Yes.
Representative Bay.
Yes.
Representative Lucas.
Yes.
And Representative McDonald.
Yes.
18-0, motion passes.
Okay, and Representative Palazzo, if you'll do the report on that. And is there any objection to consent? Okay, saying none. Finally, we have HB 1372, Representative Kesselring.
Thank you, Mr. Chair. I move interim study.
Okay, Representative Palazzo?
I second.
Thank you. Representative Kesselring, do you wish to speak to your motion?
Yes, thank you, Mr. Chair. So we heard a lot of different people asking a lot of different questions about what to add and what not to add. So I don't think we're ready to move this forward yet, but that's why I'm pushing interim study.
Okay, thank you. Representative Weber, do you have any? Okay, go ahead.
Yeah, I think the bill as it is completely unnecessary because we know what the problem is. And so I think I would have voted ITL, but I'm more than willing to interim study it because I think we heard an awful lot about directions in which this could be moved that would deal with both getting the people out of the hospital we already have who don't need to be there, which is more than half of its population, and how we appropriately support those folks in the community once they're out so that we don't have the revolving door, which was the issue that people were concerned about. So I think there are better ways to do it, and I hope that the interim study will be a true interim study.
Okay, thank you. Representative Palazzo.
Thank you, Mr. Chair. My seconding of this motion is aligned with me viewing this problem as existing and important, even if the current language is not ideal. We see that there's pretty much no free beds in our current hospital, and we are hearing that it would be solved if we just were able to move people out who are ready to be discharged. But unlike intravenous therapy that haven't killed anyone in New Hampshire, here we had a case when somebody was released early and then security guard was killed. So I think we need to study before we announce that we are releasing all those people back into community. Thank you.
Thank you. Anyone else? Okay, seeing no one, I'll ask the clerk to call the roll. The motion is interim study on HB 1372.
Representative Mazur.
Yes.
Representative McLean.
Yes.
Representative Delamus. Yes. Representative Kofal.
Yes.
Representative Palazzo.
Yes.
Representative Drew.
Yes.
Representative Noddard.
Yes.
Representative Graff.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
Yes.
Representative Nagel. Yes. Representative Woods.
Yes.
Representative Palmer.
Yes.
Representative Tejas.
Yes.
Representative Lamonte.
Yes.
Representative Bay.
Yes.
Representative Lucas.
Yes.
And Representative McDonald.
Yes.
18-0, motion passes.
Okay, and any objection to consent? Hearing none. Representative Kesselring, you also do that report?
Yeah,
It's IS. Yeah. Okay, that concludes all of the bills we had scheduled for executive session today, and concludes our business for today. As we've all been hopefully informed by now, we will be meeting, unfortunately, 2 days next week to make sure we get all of the hearings finished, so that we can go into executive session the following week on March 4th to meet the deadline for all bills to be addressed by all committees. Any questions or thoughts before we adjourn? Seeing none, we stand adjourned, and I will see you Monday.